delighted to welcome you all here in National Institute of ENT. Feels amazing to see so many smiling faces here today, and thank you so much to all the delegates and honorable faculty members for present out here. Our Congress is themed on shaping future of head, neck and thyroid cancer. As you already know, our whole program is divided into three sections. Yesterday, we covered several important topics related to the oral cavity and oropharynx, which provided valuable insights and discussions. Today is the second section, and we move forward to explore more exciting area in head and neck region, that is larynx. We hope that today's session also have been more beneficial and enriching for all participants. We are gathered here not only to share knowledge, but to strengthen our collaborative network, because excellence in head and neck care is always multidisciplinary and patient-centered. Now we are going to enter to the scientific session. At the beginning, let us enjoy a short video presentation. The next part of the session will be chaired by Professor Dr. Akhtaruzaman Sir, ex-principal, Joshua Medical College, and Dr. M.D. Saiful Islam Sir. The session will be moderated by Dr. M.D. Azizul Haq Manik Sir, Assistant Professor, Dhaka Medical College. Now, I would like to humbly request chairpersons and moderator sir come up on the stage.
Good morning, everyone. A very warm welcome to the distinguished guests and speakers for today's presentation. And Thyroid Cancer Congress. Today's second day is titled by Larynx Day. There are different topics here and presented by different presenter today. And first day and this morning there is a scientific session from the different presentation, like video presentation, and 6 distinguished guests will talk on different laryngeal topics. First, I present. There is a video presentation on different 2 topics, peace and tracheoesophageal processes. There is some time format in this session. I request all the speakers to maintain the time format. Each presentation duration will be 15 minutes. I request all the speakers to continue this session and within the time limit. Thank you. First, there is a video presentation on fees and tracheoesophageal processes.
Respected chairperson and my dear moderator and our respected and valuable audience. Very good morning. Uh, Thank you very much. Thanks once again, Mithu and his team and the ENT Institute. I am honored to be here today. Let us come to my presentation. But before going to my video presentation, I would like to show you some important things. This is the radiology. You know, this is a CT scan of the larynx. Today I will present how to insert the voice prosthesis and outcome of uh, speech and quality of speech after total laryngectomy. Before doing total laryngectomy, you have to evaluate the non-functional or dysfunctional larynx by clinically and radiologically. Radiologically, there will be through and through cartilage erosion. You are observing the CT scan, the cartilage in through and through eroded. So this is one indication. Another indication is clinically non-functional larynx. So how you will understand, see, this is a frank aspiration. So these larynx you cannot preserve, or you cannot preserve the organ. So you have to sacrifice the organ. So this important paramounts, and this fiber optic endoscopic evaluation also. See, this is the fiber optic endoscopic evaluation of swallowing. The material is going directly through the esophagus, no leak or no aspiration. This in video you can see there is there is aspiration, and the material is going to the larynx. So in total laryngectomy, this supine position, there is two types of incision. Transverse incision is always preferred nowadays with a single stoma or separated stoma. Here the incision, one incision, and another is separated stoma. Here the single incision with incorporated stoma. In the same incision, you can make a stoma. This is a subplatysmal flap neck dissection. But doing the neck dissection, see this here the neck, the tracheal card, the larynx is removing. This is the specimen. This is the the larynx, the organ, and there is total free margin in all directions. And before inserting the voice prosthesis, we must do the cricopharyngeal myotomy. Why? Because if you will not cut the circular fiber of the cricopharyngeus muscle, the voice outcome will not be good, and patient will face severe dysphagia. So you have to cut the cricopharyngeus muscle, the circular fiber especially, till submucosa. You will see the blood vessel, but don't destroy or cut the injured blood vessel. If you will injure blood vessel, the remaining cricopharyngeal segment will be necrosed, avascular necrosis, and there may be develop fistula. So be aware to injure, not to injure the vessel. This is myotomy. And sternal part, head of the sternal-mustard muscle is cut in some institution, not all. In the Memorial Sloan Kettering last time in August when I was there, I did not see. They are not cutting the sternal head. They have some idea, I don't know, but we are. I got training from Tata, so they are always cutting. I have seen if you cut the sternal head, the stoma will be very good shape, and patient can easily obstruct the stoma, and there will not be dysphagia and not be voice outcome is also good. This is the after removing the larynx, before repairing the cricopharyngeus muscle. If you give the flap, you should not insert the voice prosthesis primarily, because after inserting the flap, if you insert the voice prosthesis in the same sitting, it will not be in correct position, because after healing, the voice prosthesis will be uh, shift to another. So the voice quality, even patient cannot talk. So after healing, you see the stoma, the location, then you secondarily insert the voice prosthesis. So I will show how to insert the voice prosthesis. So trocar and cannula is inserted to the through the 8 millimeter from the cut margin of the tracheal in to the tracheoesophageal party wall. Distance is 8 millimeter. Trocar and cannula is inserted, and the pharyngeal protector is removed. Then the trocar is removed. Then through the trocar, the guide wire is inserted. You see the guide wire is passed, and at the top of the guide wire, the voice prosthesis, the Vega voice prosthesis, which is very much popular, which is silicone made. This prosthesis is fixed with the loading device, and these the the loading device has two ends. So at the bottom ends, you will insert the guide wire and it will come through the top end. And after passing the guide wire is passing and it is coming to the top end of the loading device and it is fixed in the loading device at the top end. It has two hole. It is coming to the one hole and through the another hole you will fix the guide wire so that it will be fixed and it will not be dislodged. And after uh, loading the guide wire, the prosthesis with the device, it is inserting through the glycopharyngeal segment. See, it is going. It is going. So you will push the prosthesis with the loading device by with your index finger in one hand. In another hand you will uh, you will remove this guide wire and by a dragging force, not hasty. By dragging force, and it will automatically fix into the tracheoesophageal wall. If you will give traction hasty, it may be dislodged or it may be tear. So if you will push by one finger to the through the tracheoesophageal segment, another hand you will just give a steady traction. It will come and you will feed a clicking sound. It will fixed in the tracheoesophageal. The prosthesis is very much good quality silicon made Vega, so it is not a good issue. It will be fixed. It is already fixed. You see, the prosthesis is fixed. So you will cut the lower part. This part will be the cutting in the cutting will be in the lower part so that in the esophageal end the food will be not accumulated and there will be not be fungal infection. So see how much the voice quality. Salam alaikum, Mr. Iman Ali.
Walaikum Assalam.
How are you?
I am fine.
What is your feelings?
I am with my family, with colleagues, with
He is working at
friends.
City
I
Corporation.
am doing service in City Corporation. I am fine.
He is fine. Hello, Mr. Iman Ali.
Walaikum Assalam.
How are you?
I am fine.
Can you please count 1, 2, 3?
1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 16, 17, 18, 19, 20.
Okay, thank you.
Welcome.
So we can count 20 without any rest or without any interval. So voice quality is fine. Only problem is that the voice process is very much expensive in our country. In Dr. Siddharth, in India, how much? 45,000 rupee. That means it is in our country it will be 60, 70,000 taka. So, but in India, they are getting that will not give the tax. I think tax free probably. Yeah. In Tata, subsidiary rate, but in our country it is more than 1 lakhs. You know. 90,000 or more than 1 lakhs.
Yeah, near
Near
about
1
1
lakhs.
lakh. Yeah. When I visited in annual scientific meeting in Australia, I got a bigger voice process represented. I requested them frequently, but I think there is a monopoly business in my country. That's why it is not possible to.
So we should raise our voice so that we can get it subsidiary rate or even tax free. Say in NINT, National Indian Institute, these institute can easily get these processes without tax. The price will be just half. I
So
think.
there's another like Vishal Rao, if you
Yeah, I know.
So he has devised AUM, which is almost similar to this. The only thing is the insertion mechanism is a bit different and kind of little bit cumbersome. That is cheaper than Provox.
So we are hoping this process is very good without a doubt, but price is a bit high, and the quality of the voice is also excellent. The voice outcome, and the patient can talk easily without any interval, intelligibility, and frequency, excellent. Everything is excellent, but only problem is expensive. So the patient can easily uh, uh, clean and speak easily also. In my I have done more than 100, but some patients they are using it for more than 3 years, even 4 years. But some patients within 1 year or 6 months. Is the patient's hygiene and quality of care is the only important. So thank you very much. Thank you for patience hearing.
Thank you, sir. Excellent video.
Thank you. Thank you, Professor Ali Ajad sir, for his nice presentation. Now there is second video presentation presented by Dr. Rupmen Kathan on functional endoscopy evaluation of swallowing. I would like to request Rupmen Kathan sir.
Good morning all. Now you will be seeing a video presentation on performing functional endoscopic evaluation of swallowing procedure. So I'll be taking you through only the procedure. So this procedure is mainly to observe the pharyngeal phase of the swallowing, wherein which we'll be performing two different tasks. One is swallowing task and non-swallowing task to understand pathophysiology of the swallowing. So non-swallowing task will be to understand the elevation of the soft palate and appropriate closure of the vocal cords and vestibular closure. And swallowing task will be to observe the function while we perform during food synthesis. So here the scope is at the level of uvula, and you can see the patient is trying to chew the bolus, and the green tinted food particle is coming through the vallicula and observing swallowing. So this is the moment the swallowing occurred, and you can see there is no residue post the swallow, neither as penetration or aspiration. This is considered So we'll be observing both laryngeal vestibule as well as the pharyngeal vestibule to see the residue. And also we rate with respect to the edema, if there is any edema present across the structures anywhere in the vallicula till the piriform sinus region, in the lateral wall and pharyngeal wall, and all of these things will be documented using different scales that we use, using penetration aspiration scale of 8 from ranging from 1 to 8, anywhere between that we can rate. And another scale that we use is ale pharyngeal residue scale that has different residues that can be observed anywhere between trace amount to severe amount, wherein which in the previous you can say that after the swallow there is small amount of trace quantity observed. So that way we can document the findings in the fees procedure. Now proceeding to the fees video, wherein which we have done this in post epiglottomy patient. You can observe this is entered through the right nostril. And at this level, we are observing the velopharyngeal elevation by doing a task of dana, dana, dana between oral and nasal sound, which helps us to understand the elevation of soft palate and makes us understand if there is any inefficiency towards the movement of the soft palate. Also makes us understand if the patient has any problem and challenges of nasal regurgitation can be understood from this inefficient dysfunction. You can clearly see in this patient that patient underwent glottectomy, and post-glotectomy patients may pose any challenges with respect to penetration aspiration. So thus we have performed this evaluation in this individual to check for any signs and risk of penetration aspiration for this patient. So observing the movements of the vocal cords, as you can see very well that both vocal cords are approximating well. Sorry. Yes. It's in video section, sir. I couldn't do it. So this is in the high position of the larynx where the scope is kept, where in which the food particles should not accumulate and fog the scope. And this is a near region where to observe any abnormalities anywhere in the laryngeal region. So primarily we're observing how much the vestibular closure and good laryngeal closure is getting happening or not. So in fees, laryngeal elevation can be interpreted whenever there is a height of the swallow when the patient is occurring. If the larynx is coming quite up, that we can interpret the laryngeal elevations occurring. But that is a disadvantage in fees that possibly we can understand in video fluoroscopy better. Now we are initiating with the swallowing trials. So first swallowing food bolus was given as a soft bolus. The patient started chewing and formed a very good bolus and initiated to swallow and observing if there is any signs of penetration aspiration. And patient performed a very good, efficient, safe swallow for soft food substances. And the second food bolus trial is trailing. This guides us for us in management and inform the patient about the safety of his swallow and what the further management can be done with this patient. So we have done this video during his follow-up visit and observed that he is absolutely doing well, and patient was also happy and clinician was also happy seeing the efficiency of the swallow. Since we consider the safety, we initiate with the soft bolus as the first trial rather than thin liquids as a trial. In liquids being most easy consistency also as an unsafe consistency. So in such patients we can select which type of bolus can be initiated first in the swallowing trials. So after every swallow we need to observe both laryngeal and pharyngeal space for any penetration aspiration as well as the residue. So patient was given almost 10 ml of thin liquids and observing the swallowing. During the swallowing, there will be a whiteout phase that occurs, which indicates there is a pharyngeal closure, and that is a sign that the function swallowing is occurring normally. Yes. So we can very clearly see that at the time height swallow, there is only a event of penetration occurred for the thin liquid and no aspiration observed. And that patient was advised to just do a simple post swallow cough to all the residue that is there at the level of vocal cords. where the larynx is trying to compensate very well for the safe swallow strategies and occluding and putting any liquid entry into the endolarynx. So this helps us patient as well as the clinician for biofeedback in helping the patient safely swallow. So this will be done when patient sitting in front of the screen and advising the patient to safely swallow, and asking the patient to observe any signs of filtration at the level of larynx. The patient can be educated where is the level of the larynx and what is occurring exactly during the time of swallowing. And this is the third video where in which we can observe there is a patient has feeding tube and post radiation treatment, patient an organ preservation, and you can observe in this procedure about his swallowing impairment. There is evident pooling of secretions and the secretions entering into the larynx, and there is merely airway is reduced and the patient is tracheostomized and observing to see how is the swallowing status. Patient was admitted for voicing trial. There is no signs of any movement of vocal cords. I'm quickly moving forwarding the video. You can evidently see the patient has a clear penetration as well as aspiration noted. Barium to see the residue, and it was completely coating across the larynx. This establishes this understanding that the entire larynx is having completely dysfunctional, and we are trying to take the decision what further management can be done in this patient with oncological team. Thank you. That so that fees can be essentially used in all settings to understand the if safety and efficiency of the swallow of the patient and take the informed decision along the patient as well as the treating clinicians. Thank you all.
Thank you, Dr. Rukman Gathan, for his excellent presentation. Now, our next presenter. I would kindly request all the presenters to maintain the time within 15 minutes so that we can accommodate all the presentations. I would like to request our next presenter, and next presenter is Dr. Ratan Shetty KS. Topic is early diagnosis and role of laryngoscopy, recognizing red flag symptoms, importance of early referral. I'd like to invite on the dais Dr. Ratan Shetty KS.
At the outset, I'd like to thank the organizing team for having me here. Good morning, everyone. So I'll be talking on laryngeal cancer, early diagnosis, and the role of laryngoscopy. This is basically for general practitioners and ENT surgeons. So what I would be discussing about is what are the red flag symptoms of laryngeal cancer, how is clinical examination relevant, and the relevant imaging which needs to be done, and are there any diagnostic tools which can help in diagnosing laryngeal cancer. And what is more important is the survival is significantly better when you detect the cancer early, and in advanced cancer, the survival decreases approximately around 50%. So, coming to laryngeal cancer, these are not as common as oral cancer. The age standardized incidence rate in the Southeast Asian region is around 3 per 1 lakh population, and there is a significant male predominance. Even though the laryngeal cancer incidence is decreasing as per age standardized rates, but the population is increasing. So the laryngeal cancer rate is not, number of cancer cases are not decreasing, is actually increasing because of the rise in population. What are the usual risk factors? Like in any head and neck cancer, tobacco is the risk factor. Alcohol, if tobacco with alcohol exponentially increases the risk of developing cancer. Other causes like GERD, and HPV infection, poor orodontal hygiene, and chronic laryngitis due to gastroesophageal reflux disease has been are one of the few risk factors for developing laryngeal cancer. Asbestos is banned in the world now, so it's no longer relevant. Wood does not much evidence, but also has been indicated as one of the causes for cancer. Now, why is embryology important? So the work done by Pressman et al., Tucker et al. Showed that you can do a conservative procedure based on the compartmentalization of the laryngeal structure. So these are the ones which these are the people who worked on the laryngeal specimens and showed that we can do a conservative procedure in larynx, unlike in other areas of the head and neck. So what are the symptoms of laryngeal cancer? One of the earlier symptoms is change in voice. Any change in voice beyond 2 to 3 weeks, one has to be very careful. If patient is not improving over 2 to 3 weeks, do a laryngeal examination. And sore throat not improving over since 3 weeks, foreign body sensation, also known as global sensation. In advanced stages, patient can have persistent dysphagia, pain on swallowing, cough while swallowing liquids, and late symptoms are stridor due to airway obstruction, presence of neck nodes, Aphodotalgia, usually in advanced cases because of the involvement of the deep structures, the muscle or the nerves. Unexplained weight loss, halitosis, again in supraglottic tumors, the patient may present only with halitosis, and change in voice, which usually is a hot potato voice in a supraglottic cancer and a rough voice in a glottic cancer. So patient can have hemoptysis or cough. When they cough, they can have a bloodstained sputum. So what happens if the patient does not take treatment? These will usually in advanced use. Patient usually develops in a glottic cancer, develops stridor. In a supraglottic cancer, will develop hemoptysis. Patient may end up with death also because of the stridor, and aspiration can cause aspiration pneumonia. So what is important is clinical examination. So whenever the patient presents to a ENT surgeon, a thorough head and neck examination, just don't do silo-based examination. Just don't examine the larynx, examine the entire oral cavity, because many a times around 10% of the times patient can have second primary tumors. So, what are the clinical symptoms? The patient can have laryngeal widening, the neck mass, loss of laryngeal cavities, usually in advanced cases when the post record is involved. Assess the quality of voice. If the voice is rough, that means the patient has some vocal cord lesion, that is the hoarseness of voice. If patient has a hot potato voice, then look for a supraglottic lesion. Do a mirror examination. I think most of the crowd now does not do mirror examination. All of us have at least 70-degree or a 90-degree scope, and flexible fiber optic laryngoscope is very useful whenever you have it. So what do you look for? Now you have diagnosed the case of CA larynx. So what is the imaging that you do? For all practical purposes, CT, contrast and CT scan should suffice. If you suspect advanced laryngeal cancer, prevertebral involvement, then you will do an MRI. For most cases, CT should suffice. If you have large neck nodes, get a PET-CT scan to rule out distant metastasis if you are intending on curative intent treatment. Direct laryngoscopy and microlaryngoscopy under general anesthesia. If you want to take a biopsy, many times we can do a biopsy with the fiber optic scope, and always do a pre-treatment voice and swallowing evaluation, because this is mandatory now in today's day and age. So here you have an image of a CT image of a early laryngeal lesion. You can see the top image is a early laryngeal lesion. You can see a glottic lesion confined to the glottis at the level of the glottis, and in the second image you have a paraglottic disease with suspected cartilage erosion. There is gross cartilage erosion at the posterior part of the lamina of the thyroid cartilage. So what the most important is laryngoscopy in office-based procedure. You do a direct visualization of the lesion, look at the color of the lesion, surface of the lesion, extent of the lesion, whether it is keratotic lesion, and localize whether it's glottic, supraglottic, or subglottic. Subglottic is very rare. I can count the number of times where the patient, on the fingers of my two hands, the number of primary subglottic disease that I've seen in my 10 years of practice. Usually they present with stridor. This is the vocal cord mobility and biopsy. See, fiber optic laryngoscopy with the biopsy port, you can do a biopsy in the office itself, and as long as the airway is patent. If you think that the airway is compromise, never attempt a biopsy in a office. Always do it in OT so that you have tracheostomy backup. So what are the laryngoscopic findings? So on a fiber optic laryngoscope, you can see irregular or exophytic or ulcerative lesion in the vocal cords or on the supraglottis. Look for the cord mobility, whether it is uh, mobile, restricted, or fixed. Keratosis may be present. There are potentially malignant lesions of the larynx. There's a keratosis or leukoplakic patches. And submucosal disease may be present where you may not see a disease, but there is fullness of the paraglottis. And if you have access to stroboscope, do a stroboscopic evaluation for early lesions, which may be missed on routine light examination. So what are the agents in diagnosis? Stroboscopy is something which is useful. And narrowband imaging. How many of you have narrowband imaging in your setup? All of us here. Do a narrowband imaging because it gives incremental diagnostic benefit. So basically, I will not go into the use blue-green light, that is 14, the depth, based on the differential depth of penetration of these two lights, you look for the intrapapillary capillary loops. So when there is neovascularization in malignancy, the intrapapillary capillary loops pattern changes. So what is more relevant is niche classification type 5. Anything less than type 5 is not truly indicative of malignancy. It could be potentially malignant, but may not be malignant. But type 5 A, B, C are suggestive of malignancy. There are different pictures here. Normal, where the vascular pattern is linear, and as a malignancy develops, the vascular pattern changes. What one needs to remember that in a keratotic lesion, you cannot do a NBI imaging because NBI is not very useful in a keratotic lesion. And again, when there is a mucus over the lesion, you will not be able to assess the NBI images adequately. Stroboscopy, basically it's a system where the light is shown in a, the strobe is basically a flickering light where it has a microphone, and the it just changes the light frequency few hertz below or above the vocal cord, I mean the voice frequency. So you can see the vocal cord movement like a wave. You can increase or decrease it by adjusting the frequency of the incident light. Again, assessment and swelling assessment. Why is it necessary? Compare the pre and post operative voice to document it. You know what works and what doesn't work. And voice outcome post treatment is important measure of quality of life. Swallowing evaluation in every case of laryngeal cancer, especially in advanced laryngeal cancer, you can do a fiber optic endoscopic evaluation of swelling spoken by the previous speaker or a modified barium swallow. Now, many times you need to do a examination under general anesthesia. You do a direct laryngoscopy or a microlaryngoscopy. For a vocal cord lesion, always do a microlaryngoscopic examination. For supraglottic, direct laryngoscopy should be enough. But nowadays, if you have a fiber optic laryngoscope, you can do a good evaluation of the larynx with a fiber optic laryngoscope. You assess the exact size and location of the lesion, palpate the arytenoid joint, whether it is actually mobile or fixed by the tumor, palpate the paraglottis, look for the extent of the disease. If you are planning on uh, transoral laser surgery, this is one of the first steps, whether it is amenable for transoral laser surgery. Now coming to excision biopsy versus uh, just the biopsy of the lesion. If it is a small lesion amenable for an excision biopsy, do an excision biopsy because the margins are 1 millimeter. So you can do a curative intent surgery. But if it is an advanced lesion, don't jump into excision biopsy, because we have had patients where a patient has presented to our OPD who underwent excision of the lesion, which were quite advanced and turned out to be TB larynx. So don't do that. So do a biopsy, diagnose, and then only proceed with for a extensive resection, that is transforaminal laser resection. If it's an early lesion, definitely you can do it. Now coming to the histopathology, 95% of the time is squamous cell carcinoma, and there are mucosal lesions which are potentially malignant. It could be from hyperkeratosis to carcinoma in situ to superficially invasive squamous cell carcinoma. So most of the treatment for this is transoral procedures. Patient can have underlying dysplasia or carcinoma in situ. And this is the staging for the laryngeal cancer. What is the importance of early diagnosis? If you detect a case of laryngeal cancer, T1 or T2, irrespective of the modality that you use, that is laser or radiation, the survival is over 90%. In many series, it's around 90, over 95%. So detect the lesion early. Whereas in supraglottis, the survival is not as good as 90%, but still it is good, more than 80%. So early diagnosis is very relevant, and when the stage increases, the survival decreases. And what is the key indicator is change in voice or difficulty in swallowing. Thank you. And always get an appropriate imaging, that is contrast and CT scan. Early detection gives better prognosis and voice preservation. That is very important because an advanced cancer may end up losing the voice because of total laryngectomy, or may end up having a salvage procedure also post organ preservation surgery. Thank you.
Thank you, Dr. Ratan KS, for his nice, excellent presentation. Our next presenter is Dr. Cecil Thomason, Clinical. Topic is role of imaging in the stage-wise management of carcinoma of the larynx. I would like to request Dr. Cecil.
Cavity, oropharynx, hypopharynx, up to T3, it is based on size criteria. But it is based on, in larynx, it is based on the involvement of the subside. And, if you look, the glottic, it's early stage at presentation. And compared to glottic and supraglottic, there is difference in prognosis and outcomes. In oropharynx, like there is no much difference in outcomes between a soft palate and a tonsil. But that's not the case with larynx. Glottis and supraglottis, that's an entirely different disease. And there is separate staging, staging is the same, but separate treatment. And if you look at NCCN, there is separate treatment guidelines for glottic tumor and a supraglottic tumor. And that's different between other sites. If you look into the imaging, why you need an imaging? One, to stage the disease, to look at the mucosal spread, locoregional extent of the disease, assessment of the lymph nodes, treatment decision. So based on stage, you decide the treatment. And for radiotherapy planning. And the fourth role is to have the evaluation of the disease after the treatment. So everyone know that the larynx extends from the tip of the epiglottis to the caudal edge of the cricoid cartilage. It extends from the C3 to C6 vertebra. It's divided into supraglottis, glottis, and subglottis. And supraglottis extends from the tip of the epiglottis to the cricoarytenoid joint. If you see a cricoid cartilage, arytenoid cartilage, and thyroid cartilage, same in the same CT plane, you say you are at the level of the glottis. Anything below that is subglottis, and this is subglottis. So the biggest area is supraglottis. That's a big area, and this is the largest kingdom in the larynx. And it has epiglottis, aryepiglottic fold. You have the arytenoid cartilage, the false cord, and the ventricle. So these are the subsides in supraglottis. So I will try to take you how you have to look in each CT scan at what level you are. That's more important. Second thing is how you stage the disease. This already discussed, so I'm not discussing that. This you know as a surgeon, everyone knows this. And the investigation of choice is a thin slice contrast enhanced CT scan is the standard of the investigation of choice for larynx and hypopharynx. And the MRI may be problem solving tool. Sometimes it may be a problem making tool also. It may be for the specificity of cartilage. The CT is better. The sensitivity is more with MR. If you want to assess the prevertebral muscle involved, prevertebral fascia or muscle involvement, MR may be better. In all the general situations, we generally recommend CT scan as the investigation of choice. Now, coming to the epiglottis, how you localize each sign is thing, you need to understand that epiglottis is seen at a higher level. Okay, it's a level of the floor of the mouth. Okay, so you have the base of tongue here. This is the hyoid bone. This is the thyroid cartilage. You have the base of tongue here. This is the vallecula, and this is the lingual surface of the epiglottis, and this is the laryngeal surface of the epiglottis. And this between the hyoid and the epiglottis, you have the thyrohyoid membrane, and behind that, you have the pre-epiglottic space here. This hypodense area is the pre-epiglottic space. I will discuss that later. And this is a coronal view of the epiglottis. Okay, and this is the hyoid bone, and this is the thyroid cartilage. Okay, that's how you make out the epiglottis. When you have in a lesion like before said before discuss some CT scans with there is a disease, what all things you should look. One, there is an asymmetric soft tissue prominence or thickening. Always you draw a midline, you compare the right with the left. That's the easy way of learning radiology. And asymmetric soft tissue prominence or thickening, the abnormal contrast enhancement, any definite bulky mass, and always look for the spaces like paraglottic space, pre-epiglottic space that we will discuss later. So you can see an enhancing lesion in the vallecula. Okay, this is base of tongue, vallecula, and extending into lingual surface epiglottis. So if you say it is a lesion arising in the vallecula, then this vallecular lesion extending into the lingual surface epiglottis is T3. If it is a lesion in the epiglottis, it's extending into the vallecula or even the base of tongue, that's only T2. Only when it extends into the extrinsic muscles of the tongue, that becomes a T4 disease. Till then, it is a T2 disease. And you should always look whether the pre-epiglottic space is intact or not. The pre-epiglottic space involvement is there, it's lower down, that becomes a T3 disease, and there is a high chance for lymphatic spread. And here you can see it as a bulky T1 epiglottis. Now we will discuss the array epiglottic fold. Okay, so how you look for the array epiglottic fold. Okay, this is the epiglottis here. The array epiglottic fold is seen on the lateral aspect. This is the array epiglottic fold. The array epiglottic folds comes down, lower down, and it becomes folds cone, and it is getting attached to the arachnoid cartilage. Okay, how you look for it? First you make out the epiglottis. This is piriform fossa on the right side. This is a piriform fossa on the left side. The array epiglottic fold forms the medial boundary of the the piriform fossa, and it is continuous with the epiglottis. So this is the epiglottis, and this space is the pre-epiglottic space, continuing laterally as the paraglottic fat. So here you have a tumor in the supraglottis. Here you can see a lesion in the array epiglottic fold. Epiglottis and the array epiglottic fold. Then if the two sites are involved, then it becomes T2. And you can see the obliteration of the right piriform fossa. Left piriform fossa you can clearly make out. Okay, so this is a right piriform fossa, mild obliteration. This again adds a T2 disease. It's a epiglottis and array epiglottic fold enhancing lesion with an obliteration of the right piriform fossa. Always you look, if you have a lesion like this, two things you need to bear in mind when the lesion is having extending into the piriform fossa, like extending into posterior pharyngeal wall, lesion extending anterior in the pre-epiglottic space or laterally into the paraglottic fat. Always you should look that. Again, this is a lesion involving the array epiglottic fold, epiglottis and array epiglottic fold, and this obliteration of the right piriform fossa. So when we discuss any supraglottic tumor in early disease, we are really concerned about the lymph node involvement. Any patient with a T1, T2, even the T2 disease, the patient can have a submucous, the subclinical lymph node to the tune of around 29 to 42%. So we need to treat the lymph nodes. If you treat with radiotherapy, we need to treat the bilateral neck nodes. If you're treating with supraglottic partial laryngectomy, always you try to do a bilateral elective neck dissection 2, 3, 4, because that's required because the patient is having a midline structure with high chance for lymph node involvement, although we are dealing with a T2 disease. Now coming to the arachnoid cartilage, how you look for the arachnoid cartilage? So this is the area where it is the false cord getting attached. So we will discuss the false cord and then I will show you the arachnoid cartilage. What is a false cord? It is nothing but because I tried as a radiation oncologist, I tried to learn what exactly it is. As a surgeon, you may be knowing it very clearly. But I later realized that it is the inferior most mucosal reflection of the array epiglottic fold is the false cord, also called the vestibular ligament, false cord, vestibular fold. And if you look into the incisions, always you try to look, this is the epiglottis is getting attached into the inner aspect of the thyroid cartilage with the thyroid epiglottic ligament. And this is the full score. It is the this is anteriorly it is attached to the angle of the thyroid cartilage, immediate below the attachment of the epiglottis, and posteriorly it is at the anterolateral surface of the arachnoid cartilage. So always you look for an arachnoid cartilage, then you are at the level of the false cord. Okay, here you can see the arachnoid cartilage. The trichodes have not started appearing, and you have thyroid cartilage here. You have the arachnoid cartilage, so you are at the level of the false cord, and it is just above the ventricle. This is the ventricle. We will discuss that. Just above the ventricle, that is the false cord. If you have a lesion here in the false cord, it can go laterally into the paraglottic space, anteriorly into the anterior aspect of the thyroid cartilage. Then you can go posteriorly. And always when you have a lesion here, always you look for thyroarachnoid gap. This is the thyroid cartilage. This is arachnoid. And if you have a tumor which grows posteriorly, always you can have a widening of the thyroarachnoid gap, and or then it can gain access posteriorly. So always you look that thyroarachnoid gap is involved or not. And then ventricle, so it is nothing but it is between this area. So if you look here, this area, this is the ventricle. Okay, false cord, then the ventricle, then you have the true vocal cord. Always it is very difficult to make out the ventricle in axial plane. Always you look in the coronal plane. Then, so this is the epiglottis, you have the false cord, you have the ventricle, and you have the true vocal cord. And the coronal views are important for two things. One, look for, say, if you have the early paraglottic fat infiltration. This is paraglottic fat. We have a tumor here. The early paraglottic fat infiltration you can make out in a coronal view. And also you can have a subglottic extension. Okay, I will show you in the subsequent slides. The level of the true vocal cord, so you have the thyroarachnoid muscle there, you have the arachnoid, you have the cricoid, you have the arachnoid, you have the cricoid, you have the thyroid cartilage, and also another structure which is the apex of the pyriform sinus. So these are the structures you see at the level of the true vocal cord, along with anterior commissure and the posterior commissure. So this is you look for a small slit between the arachnoid cartilage and thyroid cartilage in the posterior aspect. This is the apex of the pyriform sinus. If you see all the big boys, okay, arachnoid cartilage, thyroid cartilage, in the same plane, you say you are at the level of the true vocal cord. Again here, this is cricoid cartilage. And this area is made by this muscle, this is thyroarachnoid muscle. And what is the anterior commissure? Anterior commissure is nothing but the meeting point of the two vocal cords. And what is posterior commissure radiologically? Posterior commissure is nothing but the area between the arachnoid. This is the interarachnoid area. So between the arachnoid cartilage, this is the posterior commissure. So you make out that anterior commissure is involved or posterior commissure is involved. So to summarize, those who have joined late, okay, this is the tip of the epiglottis. Then you have the epiglottis here. So this is the median glossoepiglottic fold. It is not part of the larynx. On either side of the median glossoepiglottic, you have the vallecula. You have the pharyngoepiglottic fold here. You have the epiglottis here. Then array epiglottic fold here. You have the piriform fossa. Again, it is not part of the larynx. This is the array epiglottic fold. Then you are at the level of the arachnoid cartilage. You are at the level of the false cord. You are at the level of the vocal cord. And below the vocal cord, actually, you should not see any soft tissue inside the cricoid cartilage. If you see any soft tissue inside the cartilage, then you have to think that the patient is having a subglottic extension. That's how you make out. Now we will take few clinical scenarios. I have only 10 minutes left. Okay, the T1 disease. So the head and neck surgeon has a great role. Although majority of these patients are treated by radiotherapy, and you are the people who diagnose it. You properly say that where exactly the lesion is, doing a biopsy, and facilitate us for radiation. And this patient is having a lesion in the anterior two-third. Always we should have. That's how I expect my head and neck surgeon to give me details. And the patient is having what exactly is here? Anterior one-third, anterior two-third, posterior one-third. What about the anterior commissure? Any lesion crossing the midline? What about the posterior commissure? Any supraglottic or subglottic extension, mobility of the vocal cord? Each matters a lot. Patient is anterior commissure, supraglottic, subglottic, and they are all for radiation. And if the patient is having impaired mobility, that whole patient is also for radiation. Only if a patient is having anterior one that is free, the patient is a posterior one that is free, fully mobile cord, only we will take the option of laser treatment. Okay, you may differ. Okay, fine. I'm saying. Otherwise, all these patients will undergo radiotherapy. Okay, So you have a lesion here. It is an enhancing lesion. Again, what level? It's we are at the level of the true vocal cord because you are seeing arytenoid cartilage. You are having arytenoid here, the thyroid, cricoid. You can see an enhancing lesion there. Can you make out an enhancing lesion there? It is extending anterior commissure lesion. So if I contour this tumor radiologically, this will be my GTV. Suman, if I'm wrong, please correct me. Okay. Then here in T2 disease, this is a T2. This is two patients. T2 because here you can see no soft tissue here, but you can see soft tissue here. The aspect of this. So it's a T2 disease. So this is you need. This is your GTV. So this again always you look for either a lesion is having any inner cortex of the thyroid cartilage is involved, then it becomes T3 because and most of the time at the level of the true occult you don't have a real paraglottic fat because that stops just above that. So if in that because most of this is made by the thyroid muscle, just to lateral that it is the thyroid cartilage. If you see anything, then it becomes T3 because then it becomes you need to treat with chemo also. Here again, it is having a lesion there. It is coming down. It's a subglottic extension is present. Always you look for that. That's a T2 disease. Any supraglottic, any lesion extending in the subglottis, that is T2. Impaired mobility is T2. Then always when you have a T2 by endoscopy, it's my duty to see that it is not T3. Whenever you say hemilarynx fixity in endoscopy, my job is to rule out the patient is not having T4 disease. So whenever you have a T1, I have to rule out T2. If you say T2, I have to rule out T3. Okay, radiologically, then I have to plan treatment accordingly. Transglottic carcinoma, everyone knows I'm skipping that because of lack of time. Pre-epiglottic space, it is bounded superiorly by hyoepiglottic ligament, which is, we cannot make out that. That is hyoepiglottic ligament is nothing but the fold of mucosa which is covering the median glossoepiglottic fold radiologically. So this is the superior surface. Posteriorly, it is the epiglottis and posteriorly it is attached to the thyroid cartilage. Okay, here you have the anteriorly it is the this thyroid membrane. Paraglottic fat, so this is a pre-epiglottic space here. This you can see a lesion, enhancing lesion there, involving the epiglottis and the pre-epiglottic space, and the cartilage is intact. So it's a T3 disease. This is the paraglottic fat. Okay, laterally continuing as paraglottic fat. Here you can see the lesion is involving the, this is a left paraglottic fat is free. Here you can see the right paraglottic fat is involved here and it is lesion is involving there. This extending in the epiglottis and the array epiglottic fold. Here you can see the paraglottic fat is obliterated. The other thing you have to bear in mind whether you are dealing with an inner cortex involvement. So whenever you see an inner cortex involvement, always ensure that you have a thin slice CT scan. Okay, we use a 0.625 mm. Then ensure that it is not T4A because whenever there is a through and through cartilage, then that patient should undergo a total laryngectomy. Otherwise, the patient can be taken for chemoradiation. Here you can see always you look in the bony window also. Okay, never in see the always you look the thyroid cartilage in bony window, and you can see that there is in this involvement. You can see the inner cortex involvement, inner cortex involvement. Okay, again this is subglottic extension, subglottic extension, subglottic extension. Now the here you have a lesion. So at what level it is? This is at the level of the arachnoid cartilage. So it's at the level of the false cord. Here you have a lesion. The right paraglottic fat is free. The left paraglottic fat is obliterated. Here you can see the widening of the thyroarachnoid gap and the lesion is gaining access posteriorly here. And the patient is having again here. And this is the lesion is more or less up to here. It's a T3 because of the paraglottic fat infiltration. So T3 means these three things I have given in white and two in this yellow. This you can make out by endoscopy, hemilarynx fixity and postcricoid. The paraglottic fat, pre-epiglottic space and inner cortex. And all are treated by chemoradiation if there is no aspiration. But you need to understand that this patient is having, can be made out only by a CT scan. Another factor we always look when you're dealing with a bulky disease, whether the patient is an airway compromise or not. Whether the patient is an active stridor, definitely you should do an tracheostomy. But if you have a mild stridor and if you have a biopsy, always you have an option of giving induction chemo. And never take these patients for definitive CTRT because if this patient is taken for CTRT, patient will have a tracheostomy in between. So this patient will be maybe up to 50-10 fraction and one cycle of chemotherapy. The patient will be forced to undergo tracheostomy during treatment. So always you take patient for induction chemo, and any patient who have a bulky disease after induction chemotherapy, you rule out an aspiration also before taking the patient for CTRT. So that's important. Now, coming to T4 disease, this is a heterogeneous disease. Patient with true and true cartilage, everyone agree that this patient should undergo a laryngectomy. The patient is having tracheal infiltration, that's also T4A. The muscles of tongue superiorly, that's T4A. Patient is involving thyroid gland, T4A. Patient is having extralaryngeal spread through a thyrohyoid membrane or a cricothyroid membrane, T4A disease. So this all may be treated with chemoradiation, but always rule out there is no functional loss. Coming to T4A with this one, sorry, this you have to think that thyrohyoid membrane, cricothyroid membrane. These are areas where you can have an extralaryngeal spread, cartilage intact. Okay, I have only 2 minutes. Okay, I will try to finish at the earliest. So this you can see always you have extralaryngeal spread. Here you can make out here. This is the thyrohyoid membrane. So always what one of the thing the previous speaker has widening of the thyroid cartilage and splaying of the thyroid cartilage. Sometimes you can see a splaying of thyroid cartilage, and this is a sign of advances. Most of the time the young residents may present as a node. It is not node. It is actually something anterior. It's more hard. Okay, you have to think that you are dealing with a disease which is advanced T4A clinically itself. Okay, one area to look is thyrohyoid membrane, other is cricothyroid membrane. So if you look here, this is the thyroid cartilage, this is the cricoid cartilage, this is glottic extension. This is a minimal cricothyroid involvement. This is very important as for me because if I miss this in contouring, definitely this will occur. There will be a geographic miss, and this will the patient will have a compromise in local control. Patient. So what we are discussing so far is how to diagnose then and also decide treatment. So after T3, everyone agree that it is a CTRT. If the patient is in good performance status and patient is less than 70 years and good creatinine clearance, no aspiration. That's it. Then you take the patient for CTRT. But once the patient is having a through and through cartilage destruction, then that's different. So if you have a lesion here, so when you have T4A disease, several things you have to bear in mind when you look in a CT scan. One, what about the internal carotid artery? That's number one. And patient, second thing is that what about the thyroid gland? Whether you need to address the thyroid gland surgically also. That's also very important. The other thing we have to, when as a surgeon, as surgeons always you look the extent of the soft tissue in the anterior aspect, because whether you how you are going to construct. These are all concerns when you discuss when you look into the CT scans. And so in posteriorly sometimes the lesion is gaining. That's also there. What about the prevertebral muscle? So what about the prevertebral fascia? What about the carotid artery? What about the thyroid gland? And also the this is surgery followed by radiation. So all patients who are undergoing a surgery also should have an adjuvant treatment. If it's a pure glottic tumor, majority of the patient may have only N0, T4 N0. Only 20% of the T4 or pure glottic carcinoma patients can have a lymph node. But this patient should undergo an elective neck dissection, the reconstruction if required, and the patient should undergo an adjuvant treatment as well. Yes, I'm finishing. 2 minutes. Yeah, only 2 more slides. Coming to T4 disease, it's a highly heterogeneous disease. Highly heterogeneous disease. It can be due to encasement of the carotid artery. It may be due to prevertebral fascia involvement, or it may be due to an mediastinal involvement. So in this is a heterogeneous disease. If a patient is having a cartilage is intact and the prevertebral fascia is there, and then that patient can be taken for chemoradiation. But if the patient is having prevertebral fascia is there and the patient is having a cartilage through and through destruction, then that patient becomes a candidate for induction chemotherapy and reassess the prevertebral fascia, preferably with an MR, and take the patient for surgery followed by an adjuvant program. Yes, now coming to the last part. This imaging, this is a checklist. Always you should look whether it is a primary tumor in the glottis, supraglottis, oleum, size. This can only be made out in CT scan. For the pre-epiglottic phase, paraglottic phase, it becomes T3. Post-cricoid involvement from a supraglottis is T3. Extends to other subsites, it becomes T2. Anterior commission and posterior commission doesn't have staging implications, but there is a chance for transglottic spread. And patient can have a T4 disease, and it's also important for radiotherapy planning, whether it is cartilages are intact or inner cortex through and through anything. superior inferior extent of disease. What about thyroid gland, cervical esophagus, prevertebral fascia, thyroid artery, extralaryngeal spread, lymph nodes? Try to learn by yourself. And I will take, if I permit 2 minutes, I will, yeah, thank you. So if you have this, this is the right side, this is the thyroid cartilage, this is a cricoid cartilage. So you have a lesion there. Can you make out an minimal extralaryngeal spread here? It's a T4 disease. Here you can make out that. This extralaryngeal spread. Here, this is the paraglottic fat. This is the ventricle on the right side is involved. And you can see a minimal subglottic extension here. Extralaryngeal spread, paraglottic fat infiltration, and but the cartilage is intact. This always you look in thin slice and you always look in all planes and rule out that cartilage is intact or not. And I will give you another example and I will stop. This is at the level of the arachnoid cartilage, enhancing lesion, obliteration of the right paraglottic fat. You are seeing a lesion at the level of the true vocal cord. You cannot make out the right arachnoid cartilage here. Erosion of the inner aspect of the cricoid cartilage. Anterior commissure is involved. Subglottic extension is there. Again, and there is an erosion in the thyroid cartilage in the inner aspect. A minimal cricothyroid membrane. This may be an extension, may be there. Subglottic extension. You can make out that in the subglottic, this area. Okay, and here you can see a subglottic extension is there. And you can see a soft tissue, no soft tissue here, there is a soft tissue here. So that is a subglottic extension. The inner cortex involvement is there, paraglottic fat involvement is there, and subglottic extension is present. And the lesion is also a transglottic extending from here to the subglottis. So I'm skipping here, I'm stopping here. Notes I will skip. Okay, thank you very much for your patient listening.
Thank you, Dr. Sijal, for his nice presentation on stage-wise management of the carcinoma larynx. This session is chaired by Professor Akhtaruzzaman sir and Saiful Islam sir already on the stage. Here is our Professor Kamruzzaman sir. I would like to request Kamruzzaman sir to take a chair on the stage. Please, sir. Thank you. Our next presenter is Dr. Mohammad Abdul Karim. Topic is salvage laryngectomy is still in the last resort.
Thank you, Dr. Azizul Manik. I am Dr. Mohammad Abdul Karim working here. I am little bit nervous because this is my own field and own venue, and also there is a two good presentation by two brilliant people. One Dr. Ratan Shetty and another Dr. Sejal. Dr. Sejal always try to radiate all of patient, but when residual of disease or recurrent of disease, where you will go? I will explain that things. Okay. Assalamu alaikum and very good morning. This is my short biography. I always dream our people or our head cancer patient will get comprehensive treatment in our country. I have nothing to be disclosed. Kind permission taken from every patient. Usually, larynx is an important organ. Respiration, phonation, and protection is the main major function of the larynx. Not Indian. A Bengali patient. Bangladeshi patient, not West Bengal patient. Okay, thank you. Uh, hmm. Usually, head and neck cancer patient, 17.5% patient has been suffering in laryngeal cancer. Usually, all of the laryngeal cancer usually treated by Dr. Sejal, radiation oncologist, usually. But few cases, early glottic cancer and advanced laryngeal cancer are treated by surgeon. Usually, salvage laryngectomy is a surgery after chemo or radiotherapy when disease recurrence or disease is residual. It involves the removal of the larynx to achieve disease control and improve survival. Once upon a time, Laryngectomy was the treatment of choice in case of advanced laryngeal carcinoma. But after VA trial and RTOG trial, um, now there is a major paradigm shift in advanced laryngeal cancer treatment. Now organ preservation is the major role. Although lots of patients get chemoradiotherapy or only radiotherapy, risk of recurrent is almost 5 to 3% for early stage tumor, 25 to 50% for advanced stages. Risk of recurrence due to modality of treatment, subside of the disease, and staging, anti-staging. Usually recurrence within 3 years. Risk of recurrence usually primary site. Supraglottic cancer usually recur more than other subsite. Younger age patient is recurrence more than older patient. T3 and T4 also. Uh, this is one of my patient. He got radiation therapy due to carcinoma vocal cord, but disease recurred just after 2 years. Then I have done porectomy, and this is post-operative follow-up after 6 months of that patient. I show you some case scenario. Mr. Idris Ali, 65 years old male, carcinoma epiglottis, treated with 6 cycles of chemotherapy and 66 days of radiotherapy, completed on this year, 18th May 2025. But unfortunately, residual of disease 2.5 to 2 centimeter lesion on follow-up. Then I have done several laryngoscopy first, then telescopy, and telescopy report showed that squamous cell carcinoma. Then according to multidisciplinary tumor board decision, we have done total laryngectomy followed by PMMA implementation. In case of salvage laryngectomy, complication rate is too much high. My friend Dr. Rifat Farooq, Associate Professor, University of Sydney, they have a large meta-analysis. They showed that almost 65% of the complication rate in salvage laryngectomy patient, and most of the patient, that means 27, 7 to 28% of that patient has pharyngoperitoneous fistula. Although pharyngoperitoneous fistula is high in upfront surgery and also in salvage laryngectomy cases, it is 8 to 65%. Usually in laryngectomy patient, in upfront case, we usually start fit in 10th post-operative day. But due to high chance of recurrence rate, we started in NG feeding after 14 days, and then we started in this patient in 70 days. This is another patient. He is a college teacher, 55-year-old male, carcinoma epiglottis, treated with 6-cycle chemotherapy and second-degree radiotherapy. Then 2 months, that patient is quite okay. After that, 1.5 in 1.5 centimeter lesion and follow-up, then underwent salvage laryngectomy with good post-operative care, recovery. And we have done also in PMMF. This is after 7-month follow-up of that patient. And this is another patient. This is also residual. Have a look that in residual case, in every case is it almost supraglottic cancer. This is Hassan Ali, diagnosed as a carcinoma left supraglottis, radiotherapy 33, and chemotherapy total 7 cycle completed on February this year, but residual disease on follow-up. DLScope done, then post-operative histopathology report, squamous cell carcinoma. Then according to multidisciplinary tumor board, we decided to total laryngectomy and major migratinous flap. This is also another patient. We have done total laryngectomy and augmentation by pituitary major myocutaneous flap. This is another patient, but this patient post-operative complication of pharyngokinesis fistula, and that was healed after 2 months. And thanks to Dr. Ripon Sarkar, Dr. Shiab, and Dr. Mushfiq and Dr. Monwar, they have done a tremendous job to this patient. And after that, after 2 months, patient is recovered quite okay and healing, and fistula was subside. This is also another patient. Usually, in preoperative evaluation in every laryngectomized patient, either it is upfront surgery or it is salvage laryngectomy, detailed history and physical examination using CT scan or MRI neck to assess local extent and PET-CT for metastasis, direct laryngoscopy and biopsy confirmation, nutritional and psychological assessment, evaluation of pulmonary and cardiac fitness. That rehabilitation also is an important part of this patient. Total removal of the larynx, including epiglottis, thyroid. Permanent stoma for breathing, pharyngeal closure, and possible flap reconstruction. Post-operative care, airway management, and care of the stoma, enteral nutrition via nasogastric tube or percutaneous endoscopic gastrostomy. Wound care and monitoring of the drain, early physiotherapy and speech rehabilitation, regular follow-up for recurrence of surveillance. And but post-operative complication in case of salvage laryngectomy is very high. This is one of our patient. This is also an own necrosis. Usually pharyngokinesis fistula most common, wound infection or dehiscence, small stenosis, dysphagia and aspiration, psychological and speech difficulties, and sometimes, although in rare, carotid blowout. This is a good paper regarding functional and endoscopic, functional and oncological outcome of salvage laryngectomized patient. Survival depends on tumor size, margin, and absence of metastasis. Local control rates usually 60 to 70%, 5 years overall survival rate 40 to 50%. Quality of life improve with proper rehabilitation. But in case of salvage laryngectomy, we usually not put tracheostomy voice prosthesis at primary at that operation time. I don't know, Dr. Ratan Shetty and Dr. Ruby, what practice you have do. I think you also practice in later on to tracheostomy or voice prosthesis. Rehabilitation and follow-up history rehabilitation by tracheoesophageal puncture. This boy's outcome is very good. Electrolarynx, although it is robotic boys, esophageal space, long time and high IQ is required. Nutritional rehabilitation, regular oncological surveillance for recurrence, psychological support, and social reintegration. This is one of my patient, carcinoma vocal cord. Then he got it. He got radiotherapy. After radiotherapy, recurrence. Then I have done laser correctomy. Yeah, this is my social commitment or complemented patient. Yeah, he is a rickshaw puller. Then again disease is recurrence after laser correctomy. Then, according to multidisciplinary tumor board, we decided it to do salvage laryngectomy. Now, patient is disease free, and he is a rickshaw puller, and he maintain all expense of his family by this working. This is a emotional setting, and he always contact me and communicate me, and he have a mobile and phone number also WhatsApp, but he can't talk because I am not still put voice processes. When I call him, usually after that any person contact with me. Okay, this video is on the honor of his. আগুনের পরশমণি ছোঁয়াও প্রাণ
জীবন পূর্ণ করো, এ জীবন পূর্ণ করো, এ জীবন পূর্ণ করো দহন দানে।
Thank you. Although salvage laryngectomy remain the mainstay of treatment for persistence or recurrent laryngeal cancer, meticulous patient selection, surgical expertise, and multidisciplinary care is essential. Emphasis on post-operative rehabilitation and long-term follow-up ensure the best outcome. This is my surgical team. I always thankful to my team. Left hand side is NINT team, and right side is my private team. And my private team, Dr. Hassan and Professor Brigadier Alim, and all of his team. I am too much grateful to him. And in left side, this team is led by Dr. Abzal, Dr. Disha, Dr. Mamoon, anesthesia team. And also, I am fortunate that I am grateful to Professor Hassan Jafar Rifat and Dr. Shahu Alam, Dr. Hanif, and also Dr. Ripon Sarkar and Dr. Monowar, Dr. Mushfiq, and Dr. Shia. Thank you all. Thank you for patient hearing. Thank you.
Thank you, Dr. Abdul Karim sir, for his nice presentation. Our next presenter is Dr. Ratan Shetty KS. Topic is tailoring treatment in laryngeal cancer, when to radiate and when to operate and when to remove the larynx.
Yeah, morning everyone, once again. So I will be talking on tailoring treatment in laryngeal cancer. Some of it is controversial because some many of our colleagues may not agree, but this is the standard of care which is given in literature. So before pre-treatment evaluation, always do a good evaluation of the patient, get an imaging, establish the diagnosis, speech and swallowing evaluation. So what are the factors which are influencing treatment? Whether the patient is having a functional larynx, that is very important. Do not try and irradiate a patient who is not having a functional larynx. Whether patient has a pre-operative or a pre-treatment tracheostomy. If a patient has tracheostomy, that means the larynx is not functional. The function of larynx is to protect the airway, that is allowing breathing. That means the patient is not having a functional larynx. Is it a contraindication for non-surgical organ preservation? No. In RTOG 9111, tracheostomy patients were also included, but a significant number of them failed treatment. Again, age and comorbidities. A very old patient, better off doing a surgery, single surgery, and give adjuvant. And multiple comorbidities, not fit for surgery, then you need to do non-surgical treatment. Performance status, stage of the tumor, and patient wishes. If a patient who is having a stage 4 laryngeal cancer, he refuses to undergo surgery, then you should explain the pros and cons of the treatment options, and I always respect the patient wishes. And this is very important in Indian scenario, reliability of follow-up. When you plan a non-surgical organ preservation, you want the patient to come for follow-up, because not all patients respond to treatment. Some of them will fail, and you need to catch them early so that you can preserve the life. The non-surgical organ preservation is very safe as long as you have a very good follow. There are ASCO guidelines, there are ASCO clinical practice guidelines, there are NCCN guidelines which have recently included PD-L1 testing for laryngeal cancer. Even when the evidence is not very strong, they still included PD-L1 testing. And not very relevant in Indian scenario because of the cost involved, or in the India subcontinent scenario, that is. So for T1 and T2, that is stage 1 and stage 2, that is single modality. If it is stage 3 and stage 4, that is multimodality. And stage 1 and stage 2, it can be either laser or various forms of open partial procedures, or the standard of care, which is radiotherapy. And in stage 3 and stage 4, it is multimodality treatment. It is non-surgical organ preservation or a surgical organ preservation or total laryngectomy followed by adjuvant treatment, either radiotherapy or chemoradiotherapy. We'll go on to the non-surgical organ preservation, I mean the surgical organ preservation. So since 80s, when the JCO started using endoscopic carbon dioxide laser, so it has come a long way where not just T1, T2, even T3 and certain T4s are also being treated, but it's only in very few people are able to give good results. But in T1 and T2, especially T1, T1A, the outcomes are very good for T1 laryngeal cancer. So basically, you can divide into endoscopic laser versus open partial procedures. How many of you do open partial procedures here? Partial laryngectomy procedures is a lost art now because of the advent of non-surgical organ preservation. It could be a laryngophageal cordectomy or a vertical partial procedure where you need to have an intact cricoid ring, or extended partial procedures like extended VPL. But you cannot do a open partial procedure without having an intact cricoid ring post treatment. And for supraglottic cancer, well, that is supracricoid laryngectomy or a supraglottic laryngectomy. And for transglottic cancer, this is three-quarter laryngectomy, which hardly anyone has done. One surgeon by name Ogura is the only one who has a series on three-quarter laryngectomy. Now coming to the most important, which is endoscopic laser, which is precise, a decade procedure, no need of tracheostomy, and it is repeatable. Any lesion well visualized. So if the laryngo score is adequate, favorable, only then you attempt on a laser. You can see the entirety of the lesion anteriorly and posteriorly, and you are able to get the margins. And what is the margins for T1 glottic lesions? It is negative margins, say about 1 millimeter margin should suffice. Whereas in supraglottis, you need to be a bit more, like at least 4 to 5 millimeter margins. But supraglottic larynx usually end up having a non-surgical organ preservation. So coming to the margins in oral cavity, it is negative margins, about a millimeter, considered to be very safe. These are the various series where the laryngeal preservation rates are very high and the fire OS is also quite high. The local control rates are also very good. Now coming to radiation versus transoral laser procedure for T1, T2 oral cancer. What is the local control rate? The local control rate is similar. What about the laryngeal preservation rate? If you see the various series, especially for T1, the laryngeal preservation rate is slightly better for transoral laser procedure. However, the jury is still out for T2 diseases. If you ask me what will I choose, I will give the option to the patient. For T1, T2 larynx, if it is T1, I would always do a transfer laser surgery if the patient is willing, and if patient wants to conserve voice and he is very concerned about his voice, then even the series where there are quite a few series which have shown that the voice outcomes are good with TOLS, but he can choose RT. What about OS? OS is also similar. There is no difference. There are certain series which have shown slight towards transfer laser surgery in T1 disease, but in T2 disease, the jury is still out. So what is the role of transoral laser surgery in today's time? Only for glottic lesions and vertical partial, very rarely done now. Most of the patients undergo non-surgical organ preservation, and in post-RT failures. So in post-RT failures, one has to be very uh, clear whether he wants to do a partial procedure, because initial surgery should have been possible. Like his pre-treatment, if the vertical partial or only open partial procedure would have been possible, only then attempt partial procedures in a post when compared to radiation, which takes about 6 to 7 weeks. Dr. Chital may argue that I have hyperfractionated regimen, but it also has its own complications. It's a decade procedure, and if you find mucosal margin, even on frozen you found it to be negative, but eventually turned out to be positive, you can do a re-resection. However, if deep margin is involved, then re-resection is not going to help, and patient usually ends up having a adjuvant radiotherapy. The outcomes are inferior when you give adjuvant radiotherapy for a positive margin patient post TS. Good, because you tend to fail in the paraglottis or near the arytenoids. This is a series by systematic review by Liggy Thomas, that is from British systematic review. The local controllers are very good at around 89%, but large in T1, T2 and T3 tumors, mostly T2. Coming to advanced laryngeal cancer, that is stage 3 and stage 4, this is where the controversy exists. There is one set of surgeons who believe that surgery is the best and they knock off the larynx, especially in certain centers. And there is so people who practice evidence-based medicine. That is, the evidence is very strong for organ preservation, non-surgical organ preservation. And for stage 3 and stage 4, it is T3. Again, when do you decide? What are the factors which decide treatment? Till 1991, Dr. Cecil said the surgery was the treatment of choice. Post VA trial and RTOG 9111, the non-surgical organ preservation became standard of care. So when RTOG 9111 came, the induction chemo regimens were vilified and CTRT became the standard of care, and CTRT was given for all kinds of patients, and patient ended up having salvage laryngectomies with. So present NCCN guidelines also includes induction chemotherapy as a form of treatment, and the induction chemotherapy in bulky disease or in bulky neck nodes give induction and only then proceed for non-surgical organ preservation. So surgical organ preservation is total laryngectomy, near total laryngectomy when there is a unilateral disease and there is internal adenoid is free and not much of subglottic disease. Only then you can do a near total laryngectomy. OPL is not very great in advanced laryngeal cancers. Very few series and only in few centers the outcomes are good. So CTRT is the standard of care. Induction chemo is also one of the standard of care now. Radical RT, see, if a patient with T3 is not willing for surgery and he is not fit for chemotherapy, chemoradiotherapy, then radical RT is also a treatment option because it is definitely inferior to CTRT, but the outcomes are not as bad as we think it is. So if he has a good organ, the laryngeal function goes, and for CTRT, if patient is a poor candidate for laryngeal preservation, that is exolaryngeal disease is there, poor pretreatment laryngeal function, other contraindications for chemotherapy, and post-treatment previous radiotherapy is there, then patient undergoes TL. This is a VA trial where showed that induction chemo followed by surgery, followed by RT is equivalent to surgical arm. That is 68% survival, and the laryngeal preservation rate of 64% in the trial arm. This is the RTOG 9111. Even with the 10-year survival data, the survival has decreased over 10 years. But if you can see, the induction chemo have had a higher proportion of patients who are alive. This is Lisa Lisitra's reinterpretation of the RTOG data which was published, where she showed that the proportion of patients who were alive was higher in the induction arm because of unexplained deaths due to chemoradiotherapy, probably due to aspiration pneumonia or chemotoxicities. We do not know what is the cause, but induction chemotherapy also works and only in certain patients. But we go by evidence. What is the standard of care? If you are giving induction, give triplet regimen instead of doublet. And what should be the, whenever you're planning a trial, the trial should be laryngectomy, functional laryngectomy free survival. That is laryngeal esophageal dysfunction free survival should be there. The larynx, whichever is preserved, should be functional. And the local relax has to be recorded. And what are the recommended primary endpoints? Total or partial laryngectomy also has to be included in the primary endpoints. What is laryngectomy free survival? That is functional if the larynx is preserved till 2 years or later. And if any laryngectomy occurs within 2 years, that is not considered as laryngectomy free survival. McKenzie is a meta-analysis which showed that CTRT is the standard of care for all organ preservation strategies. And the benefit for larynx was around 5.4%. The not as good as hypopharynx or not as good as oral cavity. Now coming to chemo selection, Dr. Cecil talked about chemo selection. There are series where chemo selection has been tried, Ulf et al. And Susan Abba et al., where they give a single cycle of chemotherapy and based on response, they planned on treatment. If the response is more than 50%, they can do a CTRT. This is not a randomized control trial. This is a prospective study where less than 50% the patient underwent total laryngectomy. So you can actually do a chemo selection. Now coming to role of open partial laryngectomy, the outcomes are good in certain, that is Suarez and Sewell, not usually practiced everywhere. SCPL or CH, that is supracochlear partial laryngectomy, they say cricohydroepiglottopexy or cricohydroplexy. Problem is, how many of you have seen a SCPL patient? The voice is very bad actually. The very rough voice, better off doing a total laryngectomy with a TEP insertion where the voice is near normal. SCPL voice is extremely bad. If one has listened to an SCPL voice, even a female patient who speaks in SCPL voice, it will be very gruff and not very pleasing to listen to also. So partial laryngectomy outcomes are very good. Supracochlear partial laryngectomy outcomes are very good only in trained hands, so I would not recommend doing it. Now coming to salvage, sir has talked about salvage already. The complication rates are very high. It can be as high as 67%, but there is a meta-analysis which says that the complication rate is around 30%. So 1 in 3 patients, if you do a salvage surgery, patient ends up having complications, or usually pharyngocutaneous leak, and complication rates are very high. Now coming to transoral laser surgery, especially Weinstein et al., and he has done transoral laser surgery even for T3, T4 disease and with good outcomes. Peretti has had a control rate of about 70% for T3 disease. And these are not achievable in routine hands. You need to have extreme skill to achieve all this. So in T3, I would always recommend non-surgical organ preservation, that is CTRT, and T4A. Very certain few cases of T4A can be for CTRT, and most cases of T4A we end up having a total laryngectomy with adjuvant radiotherapy. Now coming to the survival data, what is the survival when you compare CTRT versus laryngectomy? See, CTRT versus laryngectomy, you cannot compare apples to oranges because the data is skewed, because the cases which are not amenable for so CTRT will undergo laryngectomy. So it's never it's always apple to oranges, this one comparison. But if you see the data, there is a slight trend towards better survival with laryngectomy, but at what cost? The cost is quality of life. For T1, T2, single modality, and stage 3 and stage 4, it is multimodality. And most T3s, it is non-surgical organ preservation, and most T4As, it is surgery. Surgery can be TL or NTL based on your ability and patient factors. So the evidence is quite strong for non-surgical organ preservation, where
phonation, we need a good respiratory support, adequate glottic closure, normal mucosal covering of the vocal cord, normal movement of the body on the cover of the vocal cord, and of course, adequate vocal length and retention control. All of us know about the glottic cycle. There is one opening and closing of the glottis, which makes one glottic cycle. So there are mainly two phases in the glottic cycle. So before we understand about rehabilitation, we should understand what normal physiology is. So there are mainly two phases. One is open and closed phase. In the open phase, what happens that the vocal cords, they move away from one another. In the closed phase, they come towards each other. So main vibration of the fold occurs during the closed phase when the air tries to escape through the glottis. So this leads to three types of vocal vibratory patterns: falsetto vibratory pattern, modal voice pattern, and glottal fry. Modal voice is the normal voice at which we speak. So everyone will have their own frequency of speech production and the modal voice. While the falsetto voice is produced when the vocal cord closure is not complete. There's some kind of air leak between the cords. So only the upper edge of the vocal cord vibrates and the lower edge does not vibrate. There's incomplete movement of the cover on the body. So this kind of produces a light voice, whereas modal voice, as we discussed, it is the basic frequency at which one phonates. Glottal fry happens, the sizzle radiates the patient, the covered body is essentially gone. The cover is not able to glide over the body. Because of loss of this gliding movement, the voice is not produced adequately. Of course, what we are talking about is the mucosal wave which is formed over there. So, how do we rehabilitate these patients? See, the mechanism of voice production is gone. So, what there are multiple options. One option is that we
give some new area of voice production. The other is that we give sound from some external source and we use articulators for speech production. And the best technique is, of course, tracheoesophageal puncture technique, where the lungs, we rehabilitate the function of lungs, we reuse it, and we use the vocal folds of the pharyngoesophageal segment, the mucosal folds of the pharyngoesophageal segments to vibrate and produce voices. So these are the most, these are the things which we were talking about. So non-surgically, what we can do, we can use esophageal speech and electrolarynx. And surgically, what we can do neoglottic reconstruction, which usually we do for neodental laryngectomies and all. And then we can use shunts. Coming on to esophageal speech was at one time the most common laryngeal speech technique followed. What the patients used to do was that they kind of swallowed air into the cervical esophagus. Then they will expel this air through the esophagus. This expelling air will cause the vibration of the pharyngoesophageal pharyngoesophageal segment, and these vibrations will produce sound. Eventually, our articulators will use these sounds to produce voices. But the problem with this kind of speech was that since, see, air has more, lung has more air volume. Esophagus does not have that much of space. So by limitation of anatomy, when we are producing esophageal voice, we cannot expel that amount of air which lungs can expel. So because of this functional limitation, the duration of speech production was very short. So we could not produce long sentences or big sentences using esophageal voice. So this was one of the major limitation of esophageal speech. But the advantage, what was the advantage of esophageal speech? Patient's hands were free. So we know that with tracheoesophageal puncture, if we are not using a valve in the TEP site, is expensive, by the way. It has its own cost. The patient's hands are occupied. The other thing is that esophageal speech does not need any kind of additional surgery. But patients needed to be trained for that. And that training was really not every patient was able to get trained with that. So there was some kind of failure rate associated with esophageal speech as well. Of course, the loudness and pitch control was also difficult. And as we have already discussed, that a patient could not speak continuously using esophageal speech. The problems, there were multiple other problems associated with esophageal speech. If there was cricopharyngeal spasm, there was reflux esophagitis, there were some other abnormalities involving PE segment. During surgery, there could be denervation of PE segment. And of course, as we have already discussed, the patient needs to be trained. And if the patient is not properly motivated about this kind of rehabilitation technique, if patient is not, if we are not able to educate the patient properly, it was a difficult modality to use. Cricopharyngeal spasm is something which can be taken care of, but still it was a problem. Then came the electrolarynx. Electrolarynx is basically a battery operated device. It is usually held in the submandibular region, and it produces some kind of vibrations, and this vibration, when transmitted through the muscles into the oral cavity, leads to sound production. When after that, we use the articulators to produce words. So there are mainly two types. There can be neck type and intraoral type. Neck type is the one which is commonly handheld, and the intraoral type is usually where we can put it over the stoma, and we can use one pipe kind of thing to send the produced air into the oral cavity, and this also helps in production of speech. It has its own set of advantages. It is very easy to learn, very, very easy to learn. Immediate communication is possible. No additional surgical techniques is required. And many a times when we cannot, as Dr. Kareem had already pointed out, that in salvage setting, we many a times do not go for primary TEP insertion. In those cases, electrolarynx can be a wonderful modality. And I think Mr. Rukumangatan will agree to this point. But it has its own disadvantages. One main disadvantage was that in post-radiated patients, the quality of tissue in the neck was not good, and even with electrolarynx, the vibration produced was not of good quality. So what are the other options? Neoglottic procedure and shunt technique. Neoglottic procedure had a lot of complications, so eventually it became a lost art. Shunt technique is something wherein we create a shunt between trachea and esophagus, and we divert the air from lungs through the trachea into the esophagus, and we use the PE segment as vocal cords to produce voice. There can be failures of shunt procedure as well, mainly because of aspiration to the fistula and closure of the fistula. So to bypass these things, prostheses were induced. The prostheses could be indwelling and non-indwelling. Indwelling prostheses are the ones which we commonly use these days, which Provox, which we are using in our setting, and there was non-indwelling processes which was used earlier. We are not using non-indwelling processes now. So non-indwelling process is something which can be easily kept and removed by the patients itself. Uh, so tracheoesophageal prosthesis is basically a one-way silicon valve. It basically serves as a conduit, as we have discussed. It has got two flanges, one on the inside and one on the outside. Inside is on the esophageal side, outside on the tracheal side, and and it has one valve inside, and it prevents the aspiration of food or liquid from esophagus to trachea. There can be primary TEP technique. There can be secondary TEP technique. Primary TEP is when it is done during the surgery. The tracheoesophageal puncture is done and the prosthesis is inserted. It had got its own set of advantages. Single procedure, done in same setting, early rehabilitation, higher confidence, better education and training of the patient, all this. But some conditions are difficult to cater to with primary processes, especially large resections, reconstruction with some kind of flap, salvage surgeries. So in those cases, secondary TEP is something which is preferred. It is important to understand how do we do tracheoesophageal prosthesis. So TEP is basically, it is performed in the midline, and puncture site is usually made around 1 to 1.5 centimeter below the upper layer of the stoma, and the intervening tissues between the trachea and esophagus are punctured in the posterior wall of the esophagus, and after that puncture is made, put a prosthesis over there. We have discussed what are the advantages of TEP. Important thing is to understand good patient selection. For TEP, a good pulmonary reserve of the patient is very important. Many of our patients who developed laryngeal cancer, they can have some problem with pulmonary reserve as well, because they might have some kind of emphysema, some kind of problem in the lung, some fibrosis, any kind of issues. Uh, as we have discussed, the contraindications for primary TEP are extensive surgery, patient is not psychologically prepared, patient has a doubtful ability to cope up with processes. This is a very important point. Of course, if the patient has impaired hand dexterity, if the patient does not have both hands, that is an obvious contraindication. We should, by and large, attempt for primary TEP whenever possible. It has got advantages of early rehabilitation, while the secondary TEP, which is usually performed 6 weeks following laryngectomy, it gives the patient time to develop esophageal speech also. So it has its another advantage, that we can train the patient in this period for esophageal speech also. There are many kinds of processes which are used in TEP. What we are doing nowadays is Provox processes. Earlier, Planjay processes and Groningen button were used, which were kind of non-indwelling processes. But I would like to highlight these two processes mainly. This is one duct-built processes, which has got a large beak in front. This used to go inside into the esophagus, and the other was outside into the trachea. And because of its long length, it was kind of a high pressure system. Eventually, we shifted to Provox processes, which is an indwelling low pressure system. It has an extended lifetime with proper and clear maintenance, good maintenance. We can use it for a longer period of time. Both have their own advantages and disadvantages. The indwelling and non-indwelling processes. Indwelling processes can be left for 3 to 6 months. It requires a specialist to do the job. Less maintenance, more cost. And while non-indwelling processes can be managed by the patient itself, but it usually has a very low shelf life. There can be problems with TEP insertion. There can be leak through the processes, leak around the processes. Patient can have immediate aphonia, dysphonia. There can be hypertonicity problems. There can be delayed speech. But before doing that, we have to ensure that the patient passes its esophageal insufflation test. And uh, coming to the problems which we usually encounter with TEP is, of course, improper location of puncture site, inappropriate site of puncture site, cricopharyngeal spasm, leakage through the prosthesis. The location of TEP it is very important. It should be at 12 o'clock position of stoma. Should be 1 to 1.5 centimeter from tracheocutaneous junction. If we place it little bit superiorly, the patient can find it very difficult to occlude it. And if it is placed very deep into the trachea, then it is very difficult for the clinician to take it out or to put another TP in the future or to clean it. So the cleaning and maintenance becomes very difficult if it is put lower down. It is important to understand the management of leak through the prosthesis and leak around the prosthesis. If the leak is through the prosthesis, the solution can be, of course, replacing the prosthesis. But at many times, we can also see whether there is some kind of fungal infection. We can try to treat it with this antifungals. We can try to see if there is some kind of other issues. Patient is not able to clean the processes properly. And if the leak is around the process, it can be a problem related to the size of the prosthesis. We may need to put some kind of valve over there, or many times the party wall thickness can get affected, and in that case we may need to resize it and replan our processes. I'm really thankful for all of you to sit so patiently and listen to this from a surgeon. And I would really also encourage Dr. Mr. Rukmanganathan to give his inputs also on this topic. Thank you so much for patient hearing. Thank you so much. Any queries?
Thank you, Dr. Ravi Shankar, for his nice presentation. I would like to invite our next presenter, Dr. Farooq Rifat, sir. The topic is laser precision case-based approach to laryngeal lesions.
Good morning, everyone.
This is online presentation.
Yeah. Good morning, everyone in Bangladesh. It's Rifat. Can you hear me? Hello.
Hello.
Hello. Can you hear me?
Yeah. Dr. Rifat, do you hear me?
Yeah. Good morning.
Perfect. Good morning.
Good morning, everyone. Dr. Farooq Rifat here. Thank you for inviting me. I'm sorry I can't be there in person. I will present on transoral laser surgery. I'm just going to put up my. Just 1 second. All right. You should be able to see my screen now.
Yeah.
All right. Good morning, everyone in Bangladesh. I'm from Sydney, Australia. I'm an associate professor of ENT head and neck surgery with an interest in transforal robotic and transforal laser surgery. Thank you for inviting me. Dr. Karim kindly requested me to speak on lasers when we had him as president fellow last year. And we hope to have him back again in our institution. So I'll talk to you for the next 15 minutes. And if you've got any questions, please put up your hand or ask me at the end of the presentation. So I think the first important thing in transforal laser surgery is to avoid flying solo. This is not something that you want to do on your own. You need to have a laser team of an anesthetist, of pathologists, of radiation oncologists, and of course us as surgeons, so that we can find the most appropriate treatment for every single patient that we encounter, so that we obtain the best outcomes. Because not every patient, as we've heard from the earlier talks, is suitable for surgery, and some of them may be better suited for radiation. But it's that interaction as a team that's really important when we choose patients for surgery. So who do we have in our laser team? Of course, we have radiation oncologists, we have surgeons, we have institutions that provide us the infrastructure and our laser therapists, our speech pathologists to provide us allied health support for voice rehabilitation, and of course our research officers who provide us a good analysis of our outcomes to ensure that we are meeting benchmarks and keeping us honest in our results. So this is our MDT. Every patient that we see is discussed here, where we put up their radiology, put up their pathology. This happens on a weekly basis. This is our multidisciplinary tumor board, which is attended by everyone, and every patient with a malignancy is discussed in this forum in order to discuss what the appropriate treatment for them should be. So I'll take you through a case because I think that's the best way to assess where laser fits in the scheme of things. So this is a standard lesion that we might all encounter in our clinical practice. It's a patient with a hoarse voice on the background of a 30-pack year smoking history. He's referred to our clinic. And on video endoscopy with or without narrowband imaging, this is a particular research interest of ours. It's a wavelength restricted endoscopy to allow us to identify early mucosal malignancies with greater sensitivity. But I won't talk too much about this because it's not the topic of this talk. But this is essentially what we see. So we see a lesion involving the right vocal cord. It's sparing the anterior commissure. It's leukoerythroplakia extending across the entire length of the right vocal cord and with normal vocal cord mobility. So we know that this is a T1A lesion, potentially. We don't have a biopsy at this stage. So the key questions are, what is the pathology that we might be encountering? Is this a benign lesion, something like candidiasis, hyperkeratosis, or is this much more likely to be malignant so that we can choose the appropriate modality of treatment for this patient? Now, it might be tempting to go in and do a quick biopsy of this lesion, but in my opinion, which I'll cover in this talk, lesions such as this in a high-risk patient may be better off performing a transoral laser excision, which provides us the diagnosis and maybe provides us the therapeutic resection at the same time, rather than doing 2 trips to the operating theater where we do a biopsy first and then either refer them to someone else for transoral laser surgery or do a second resection, which sometimes becomes more difficult to obtain margins because of scarring from the first biopsy. So when we assess these lesions, again, these are 2 similar lesions that we encounter in every patient that we see. We have to assess the patient factors. Does this patient have a smoking history? What sort of access they have? Are they obese? Are they going to be a difficult laryngoscopy? Is laryngeal exposure going to be a challenge? Do they have significant anesthetic comorbidities? And disease factors. Which is the disease involving the anterior commissure, such as this lesion on the right, where we see this. I should clarify, there are 2, on both these lesions, you see that there are 2 parallel endoscopic images. On both images on the left-hand side, these are white light endoscopy, and on the images on the right-hand side, these are what we call narrowband imaging, which we have published extensively on. This is, again, wavelength restricted endoscopy. It uses a green and blue light filter in order to enhance the mucosa, enhance the vasculature of the mucosa, where we look for these little brown dots, which you can see on the right-hand side of the screen that are circled in blue, and that is clearly where the malignant change is occurring. That is where the vasculature of the lesion is changing. So we assess disease factors in terms of the location of the lesion, in terms of the extent of the lesion, vocal cord mobility, whether it affects the anterior commissure, whether it affects one side or both sides, and of course surgeon factors. Is the surgeon trained in laser? Are they able to obtain adequate margins? Do they have the appropriate institutional support? Do they have the equipment? Do they have the anesthetic support? And so on. All of these factors are important in making what would be the optimal decision regarding the treatment. So again, we see a very similar lesion. This is a lesion affecting the left vocal cord. Here it's affecting the entire vocal cord, extending from the arytenoid all the way to the anterior commissure. In this patient, we performed a transoral laser lead excision biopsy. This patient was not a two-stage procedure where we obtained a biopsy followed by a formal excision. We performed a one-stage single-sitting left cordectomy, laser cordectomy. And of course, there are different anesthetic techniques that we can use in these lesions. And I think in whichever institution you work, it's important to discuss with your anesthetist what sort of anesthetic technique they are comfortable with. We use a technique called Thrive. Again, we have finished extensively on this. That's transnasal humidified oxygen, rapid instillation ventilatory exchange. That's what it stands for. It uses high flow nasal prong oxygen to 100%. And with tubeless anesthesia, we obtain an excellent laryngeal exposure with a Dido laryngoscope. This is an an endolaryngeal laryngoscope, which provides us adequate exposure of the larynx in order to obtain adequate access and adequate margins. So now, there are that use jet ventilation. I think you can get very good access with jet ventilation as well, if that's your local expertise, or microlaryngoscopy tube. Microlaryngoscopy tubes can make it a little more challenging. You might need to reposition the tube a little bit during the procedure, but nonetheless, with good access, you can obtain clear margins. So this is the important discussion that you need to have with your anesthetic colleagues. So when you excise these lesions, it's important to remember laser is not the only way to do it. So I would discourage you to do a smash and grab biopsy, as we call it. This is done by a lot of our registrars. Sometimes they don't even use a microscope. Put a laryngoscope in, and they use the big biopsy forceps to obtain multiple biopsies of the lesion. That's called the smash and grab technique. It is unrefined. It results in significant vocal cord scar. And we believe that a lot of the poor outcomes that people have described from transoral laser is actually because the initial biopsy was done badly. Because if you do a bad biopsy, you have a significant scar sulcus, which results in glottic insufficiency and a poor breathy voice afterwards, which gives you a poor voice outcome, which may not happen in the radiated patients. So I think it's important when you compare laser with radiotherapy that you compare the same lesion, not different lesions, because that can bias your voice outcome. Cold steel excision is completely appropriate. A lot of people can do that very well. They do a hydrodissection, use fine micro scissors, and you can obtain the same sort of results as you can with transoral laser. Laser, of course, gives you better precision, better hemostasis. That's our preferred technique. I think it was covered in one of the earlier talks, the distinction regarding what is the appropriate management of laser versus radiotherapy. You do have to take into account what is the voice demand of the patient. We do obtain a preoperative speech pathology assessment to determine what is the appropriate treatment, because in a patient who's a school teacher, who's a school principal, a university lecturer, there are times when I think transoral laser can give you a worse voice outcome. And so in those patients, radiation may be an option. But of course, you need to discuss these with the patients in the MDT. So the vocal demand, the occupation, whether they have any other concurrent factors that may result in a poor voice outcome, such as allergies of the upper airway, reflux, and so on. So we see these patients in our voice clinic. We do stroboscopy and stroboscopy, which allows us to obtain adequate assessment to counsel them better regarding their voice. So this is how we do the procedure. We use a Dido laryngoscope. We use transnasal 100% oxygen through a Thrive technique. There are occasions when we would use a distal jet ventilation, which is this tube here, which is called the Hunsaker tube. I think it's much harder to do it with supraglottic jet ventilation because the lesion vibrates. And sometimes you have the lesion almost excised, and the anesthetist tells you need to stop, and you have this lesion which is vibrating in the airway. You get aspiration of blood into the airway. So I think it's a less than ideal technique. And I think distal jet or Thrive techniques are better techniques techniques of anesthesia when you do these lesions. We have a laser safety officer in our room to ensure that laser safety protocols are maintained during the procedure. So this is the setup that we use. This is the surgeon at the head of the bed. This is our scrub nurse, our instrument table, our laser, our microscope, and the anesthetist at the foot of the bed. This is the video tower that everyone in the room can see. And of course, the surgeon looks through the microscope. The most important thing when we do transoral laser is the assessment of the pathology result. I think we use a cucumber technique. There are many different techniques, cucumber or cordboard pinning. I think the communication between the pathologist and the surgeon is vital because, as we heard from one of the earlier talks, the margins that we're dealing with in transoral laser is millimeters. So if the lesion is not orientated properly, if the lesion is not set up properly, your pathologist is going to report bad margins, positive margins, which may or may not be true. And those patients may result in unnecessary secondary resections, so they have more normal vocal cord tissue removed, and that results in worse voice, or they have unnecessary radiation. So I think the laser team that performs this procedure, the pathologist and the surgeon has to be in constant interaction so that we can assess this, the margins appropriately in order to decide whether this patient needs a second look procedure, whether they have clear margins, or whether they might benefit from radiotherapy. So going back to this lesion again, the surgeon needs to consider what type, if it's malignant squamous cell carcinoma, whether it's low grade, high grade, what sort of margins, whether it has a cohesive pattern or whether it has a discohesive pattern. Discohesive patterns have a worse prognosis. That's where you have individual islands of SCC, which have a deeper presence compared to the margin of resection. Those patients, despite the fact that your margins of resection may be positive, may sometimes need adjuvant radiotherapy. So the surgeon needs to realize whether he's got the lesion, whether he needs to go in again. He needs to realize that further procedure leads to greater vocal cord scarring, and sometimes it may be better to refer this patient to radiation. So in early vocal cord cancer, radiology has a very limited role because ultimately this is an endoscopic diagnosis. Very rarely the anterior commissure can be involved, and Boyle's ligament and the inner perichondrium of the thyroid cartilage may be involved, which may upstage the cancer. And some of those patients who do badly with anterior commissure disease may actually have inner perichondrial involvement, which results in recurrence. And eventually, some of them may even need salvage laryngectomy. So those are not T1B lesions. They're actually early T4 lesions because the inner perichondrial involvement. So those lesions are actually upstaged through the radiology, but that's very rare. The radiation oncologist is your friend, it's your ally in treatment in transoral laser, because it's a team approach between radiation oncology and surgery that gives you the best results. So again, I won't dwell on radiation. I think you've had an earlier talk on radiotherapy, so we'll skip this slide. But I just wanted to talk about advances in radiation have actually improved voice outcomes significantly. You can do single cord radiation, IMRT, narrow field radiation. I'm not a radiation oncologist, but basically it's important to realize that normal tissue toxicity can be significantly minimized, and surgery is not necessarily the only approach for these patients. So these are our other members, our nurses, our audit and data managers, our speech pathologists in our laser unit. We tell all our patients that they must stop smoking. Ultimately, the outcomes of surgery are poorer. Patients who continue to smoke. We need to optimize their reflux management or their allergy in the upper airway, because allergic laryngitis or reflux laryngitis will give you a worse outcome after transoral laser resection. In some patients who have significantly poor voice after laser surgery, there may be a role for injection augmentation of the defect, but that's usually done after a period of time when we can ensure that they're completely recurrence free. Again, the summary, when you see a patient in the community, I know we have a varied audience today. I think it's important that you refer them early for transoral laser because the early diagnosis results in better outcomes. You need to refine your biopsy techniques. Consider a one-stop shop where you excise and treat the lesion at the same time. As part of greater education, I think events like today are excellent. You need to organize dissection courses. We can proctor future laser surgeons to guide them through on how to set up a laser service in their hospital, publish, and I think peer review your results. We publish extensively on our laser treatment outcomes, which are available on PubMed. But I think that's how you improve. That's how you stay honest as far as your treatment outcomes go. So remember not to fly solo. Success in transoral laser result requires you to choose your lesion appropriately, requires you to coordinate with your team, with your speech pathologist, with your radiation oncologist to decide who is the appropriate patient for laser treatment, and then follow up your patients closely. This is our team. This is when we had Marshall Strom and Andrew Blitzer from New York attending our laser course in Sydney a few years ago. But again, it's courses like this, it's events like today that allow us to improve. So thank you for your time, and I'm happy to take any questions.
Thank you, Dr. Farooq Rifat, sir.
Dr. Rifat,
Yes.
কিছু প্রশ্ন আছে তোমার সাথে আমরা বাংলায় কথা বলি তাহলে এখানে সবার কাছে মনে হবে তুমি আমাদেরই লোক। আমাদের সিনিয়র টিচার আছে প্রফেসর মনোয়ার হোসেন স্যার, আমার এমবিবিএস এর টিচার, উনি ময়মনসিংহ মেডিকেল কলেজের প্রিন্সিপাল ছিলেন। উনি কথা বলবে, আমাদের ডিরেক্টর স্যারও কথা বলবে তোমার সাথে। আর আমার একটাই কোশ্চেন, কোনো কোশ্চেন নাই, আমার মনে হয় তোমার প্রেজেন্টেশন এক্সিলেন্ট, আউটস্ট্যান্ডিং। তুমি কবে বাংলাদেশে আসবা, কবে আমরা সরাসরি তোমার সাথে কথা বলবো, তুমি চাচ্ছ আমাদের এখানে রোগী দেখতে, আমরা কবে দেখবো, এটাই কোশ্চেন, অন্য কোনো কোশ্চেন না। এখন মনোয়ার স্যার কথা বলবে, তারপর আমাদের ডিরেক্টর স্যার, তারপর মোস্তফা।
হ্যালো, আসসালামু আলাইকুম. I'm Professor Manohar. I have a question regarding the keratosis. Actually, this keratosis, it mimics like T1 type of carcinoma. Yeah. You tell so many things regarding the biopsy and the total excision. My question to you: what is the actual or the ideal procedure in cases of keratosis? Whether we will do excisional biopsy or biopsy followed by excision. This is my question.
English.
English.
Okay, sure.
As because it is a scientific session. So.
Sure, understand. So I think, look, keratosis is a pathological diagnosis. I think when we see the patient, what we're seeing is a thick, wide leukoplakic lesion on the larynx. Look, it all depends on what type of experience, what type of endoscopic equipment you have. And I think this is it's a very complex question because you can make the answer really simple or you can make the answer really complicated. But the practical answer is, if you're using a fiber optic endoscope that you are viewing with your eyeball, which even in Australia today, a lot of community ENT surgeons still do. So we have great video endoscopes in our teaching hospitals, in our university hospitals, but in community practice, a lot of private practice ENT surgeons are using eyeball fiber optic endoscopes. So the diagnosis, when you see a keratotic lesion, depends on how accurate a diagnosis you can make from the patient's history. So this patient is a smoker, you're using an Olympus or Pentax or Swartz video endoscope, you're going close to the larynx, and you're obtaining fine mucosal detail, and you can be confident that this is a T1 vocal cord cancer in its appearance, then I think a transoral laser correctomy is a better option. Because in trained hands, you can do a simple operation, you can obtain the diagnosis, you can get the treatment all at the same time. Now, if you're using a fiber optic eyeball endoscope and all you're seeing is a white patch on the vocal cord, And that lesion can be candida, that lesion can be keratosis, that lesion can be severe dysplasia, that lesion can be an early malignancy. In that scenario, I think depending on resources, you can do a biopsy first because your fiber optic endoscope is not adequate to obtain the diagnosis with great confidence. Now, when you do this biopsy, I think it's important not to be not to take a very rough biopsy, because if this patient ultimately needs transoral laser, you will obtain a much better voice outcome if your biopsy is gentle. So you can do a hydrodissection, you can do a cold steel, mucosal dissection, you inject some saline adrenaline into the vocal cord, into the superficial lamina propria. What that does is that it balloons the vocal cord, you get a nice plane, and you can do a very superficial mucosal excision. It will give you the diagnosis. And then if you are trained in laser surgery, you can do that second stage procedure. If you're not, you can refer them to places like the Bangladesh Institute of ENT Surgery, where they have expertise to do it. So I think the answer, Professor, the answer to your question depends on how much experience, how much sort of resources you have, and how precise your preoperative diagnosis can be. I don't think there's a right or wrong answer.
Do you suggest frozen section biopsy?
We do use frozen section biopsy in transoral laser. I think it is very useful because we are in large lesions, especially in T1B lesions. I do use frozen section, particularly in the anterior commissural, because that is an area which is difficult to access, difficult to excise, and sometimes exposure can be inadequate. For a standard T1A, I don't use any frozen sections.
Sir, here is our oncologist, Sir Mustafa Shuman sir, say something, few words about laser precision and radiation in case of early laryngeal carcinoma.
So thank you, Dr. Rifat. It's really nice to get you over here, though virtually. So and bringing these very newer topics to us, comparatively newer topics. So my question to you, so what opportunities you do see laser therapy in, particularly in residual case, in recurrent case, early glottic cancer?
So residual or recurrent, you mean after they've had radiation treatment or after they've had one surgery? So residual means you've done one resection, you've still got residual disease?
No.
After radiation therapy.
After radiation therapy, because we are very familiar with radiation therapy in early glottic cancer.
Yeah. So I think, look, I think if you are going to use transoral laser for post-radiation recurrence, you have to be very careful. It is described. There are institutions that do it very well, and if you look at their results, they seem to get good results. I'm still very careful in post-radiation persistent disease because I think the interpretation of the pathology can be difficult. Sometimes there is a lot of scarring and fibrosis within the larynx. And while you might obtain an endoscopic view that suggests that transoral laser has excised the lesion, you might still have residual disease in the larynx. So I think transoral laser salvage for radiation failure, or let's call it radiation persistent disease, is something that needs to be done with extreme caution in very advanced centers where the patients can be followed up very, very closely. I think the key to that is follow-up, because in patients who have residual disease after radiation, biology has selected out the patient for you. You know this patient may not get a good outcome because it's very, very rare. Remember that early laryngeal cancer with radiation treatment, the disease-specific survival is in excess of 95%. So if they are failing, they have bad biology. To then salvage them with laser, I think you have to be very careful because I think you might leave residual disease behind, and those patients will end up needing salvage laryngectomy. So I'm not going to say no to it. I think it depends on where the recurrence is, how big the recurrence is, what sort of follow-up this patient is going to have, and I think only then you can make that decision.
Thank you.
Thank you, Dr. Rifat Sharif. I am Colonel Azad from Combined Military Hospital, Dhaka. I want to ask you how you are assessing your margin in transfer laser in the frozen section or final histopathology. And if any report comes positive in final histopathology, what you are doing?
Okay. So the first to the question, I would very rarely use frozen sections. Like I said, if it's involving the anterior commissure and so on, I would. We have the same pathologist. I think this is very lucky, and I think a lot of centers may not have this. We have the same pathologist report on all the transfer laser cases. So, like I said, we pin the specimen on a corkboard with we mark the margins fresh before formalin fixation. Because I think it's important to understand that after formalin fixation, you get significant artificial shrinkage of the specimen. So we actually mark the margins. When I was in Philadelphia with Professor Weinstein to do transoral laser and transoral robotics, he does exactly the same thing. The margins are inked while the lesion is fresh, so that the pathologist reports the margin before formalin fixation. So that's the first thing. If you don't have the same pathologist, I think frozen section is useful. And the third question is, what would I do if the margin is positive? It depends. Look, ultimately, the surgeon has a gut feeling whether the positive margin is a pathology artifact or if the positive margin is a true positive margin. As a surgeon, when we are doing transoral laser, we can very clearly see the interface between normal tissue and cancer. We are working at high magnification. We know that laser interaction with tumor cells and with normal tissue is different. So if we feel that it's a pathology artifact, I would take them back for a second look in 6 weeks after the larynx is healed and re-biopsy the larynx. And if that is clear, then our MDT would consider that to be clear. So we only make a final decision about margins after the second look if the first biopsy is reported as positive. The second scenario where the surgeon feels that sometimes the preoperative assessment, you feel that this lesion is resectable, but when you're operating, the specimen may have significant extension into the paraglottic space. It may have supraglottic extension. It may have extension into the ventricle, into the subglottis. In those scenarios, your office or clinic-based examination may have underestimated the size of the lesion. In that scenario, the positive margin may be a true positive margin. And taking them back for a second resection would involve further resection of the larynx and may give them a very bad voice outcome. And in those patients, I would work with my radiation oncologist and refer them for adjuvant radiotherapy. So I think there is no one size fits all. I think it depends a little bit on the surgeon's experience, the pathologist's experience, and whether it's an artifact of the pathology or whether it's a real disease left behind scenario.
Thank you, sir. Thank you for your time and nice presentation, sir. Thank you very much.
Thank you for your time. Thank you very much.
We are already out of time. I'm inviting few questions for the rest of the presenters from the audience. Any question from the audience to the rest?
Thank you very much. I have a series of questions, to the very expert keynote speakers of this session. I want to advance us actually to get home messages as I am going to leave back tomorrow, back to my city. Thanks to all the speakers for all the brilliant and very insightful presentations and sharing your experiences with us. I am from Chittagong, from Professor Dr. Malik Afroz, self-retired from undergraduate medical study just recently, based on the private medical college, and at present working as senior visiting consultant in a corporate hospital in Chittagong. And I like the quotation, please do not fly solo. I liked it very much. The last presenters, Dr. Rifat's very intelligent quotation. Yeah, but we have actually in Chittagong, I think we are very much backdated, and sometimes we need to take our decision ourselves. I have the questions I do have. For diagnostic purpose, the choice is DL biopsy under general anesthesia or FOL biopsy under local anesthesia. Which one? And I do prefer DL biopsy under general anesthesia. DL biopsy or precise debulking of the disease in a limited carcinoma, CL larynx T1, T1A, T1B, or T2, and biopsy. Do you consider the word debulking? Because my radiotherapist, they recommend it before radiotherapy, and I prefer debulking. DL biopsy over precise debulking under, preferably under microscope. And the next question is DL biopsy under microscope, endoscope. I am used to working under microscope from the very beginning of my clinical life to deal the benign lesions of the vocal cords, vocal cord nodule, polyps, some cyst arising from the valleculae, ventricle, and I prefer micro laryngoscopy over endoscopy laryngoscopy under general anesthesia. So which one
Thank you, madam.
you think better? And precise excision choice is cold steel or laser CO2 diode or coblation, which one? Because we are, I know some of us here also, we are practicing coblation. So which one do you prefer?
Thank you, madam. I am requesting one of the presenters to answer this question. Anybody? Please.
And another question, can I?
No, madam.
Okay, okay.
I'm sorry, I was not presenter, but I can answer the questions on their behalf. So your first question was DL biopsy under GA or FOL under local. Now, when you are doing a clinical evaluation in the OPD as an Hopkins or an ideal evaluation, you know what is the site of the growth. Now, if you are expecting that this patient is going to go for surgery, considering the imaging findings and all, you would do a telescopy evaluation under GA. Reason behind, you will take biopsy, at the same time you will assess the entire laryngeal and hypopharyngeal area. This will give you an idea about the choice of your surgery, the choice of your reconstruction. So that will help you to plan your surgical decision making. You would want to know whether the disease is reaching into pyriform apex, going into the post-cricoid region, because this is not possible under the local. Okay. So if this is an hypopharyngeal malignancy coming onto larynx, you would want to do a telescopy under under GA, because you want to see these niche areas which are not possible to see in the OPD evaluation. And that will give you a plan of treatment and plan of reconstruction that you would require, which will help you to explain to the patient need for reconstruction, if at all. If it is going on to the postpharyngeal wall, post-cricoid, you might need another additional procedures. If it is purely glottic lesion, both cords are mobile, you know that you would go for an organ preservation condition. In that case, probably an OPD-based biopsy is sufficient. Okay, you can do it with a 70-degree flexible biopsy forceps, you can do the punch biopsy, and for diagnosis, you want to do it. Yes, there are instances where the patient is to be planned for either neoadjuvant chemotherapy or for definitive radiation and chemo, but the bulk of the tumor is so that the patient is in stridor. That if the patient goes for radiation, there will be an initial edema which will worsen the stridor and the patient may be compromised. In that cases, probably you would want to debulk the tumor so that airway compromise is prevented, and then the patient can safely undergo the entire radiation and chemotherapy. I hope that answers your question.
Thank you, sir. Thank you. We are already out of time. Thank you for today's session one presenter, Professor Cornel Ali Azad, Dr. Ratan Shetty, Dr. Sizal, Dr. Abdul Karim, Dr. Ravi Shankar, and Dr. Farooq Rifat, sir. Thank you very much. Thank you for your nice presentation. We are already out of time. I am requesting today's chairperson, Professor Akhtar Jaman, to say a few words and put comments on the presentation.
Nothing to comment. First of all, I give thanks to organizing committee for such a nice organized seminar conference, and I give thanks to the video presentation, and all the topics were very nice, and the presentation was nice, and it is such palatable and interactive that I think all the audience, including me, have been much benefited from this session. And lastly, I want to give thanks to all the head neck surgeons, especially who have given attention to this site and who have taken the all responsibilities of 170 million voice box of Bangladeshi population to their shoulder. And I want to request them to give more training and make more surgeons in this field. Thank you.
Thank you, sir. Thank you very much. We are in the session. Our next session will be start soon. Thank you very much.
Our profound thanks go to our distinguished chairpersons and the moderator and the speakers for their valuable contributions. I would like to request the honorable sirs to take their respective seats in the audience and enjoy rest of the session. We will now move on the next session, which will continue to explore critical topics in head and neck care. This session will be chaired by Professor Dr. Mohammad Monwar Hussain sir, ex-professor of National Institute of ENT, Professor Dr. A. Alam Chaudhuri sir, Professor of Bangladesh Medical University, Professor Dr. Mohammad Akhtaruzzaman sir, and the moderation of this session will be done by Dr. Mohammad Jahidul Islam. Now I would like to invite the respected chairperson and moderators, sirs, to come up on the stage and continue the second session. Thank you for your attention and engagement today. Our working refreshment break is already started and the next session will begin promptly at the time of 11:15 a.m. Please enjoy your tea and coffee from the 8th floor. Please keep in mind that no food and drinks are allowed inside the auditorium.
Another announcement, our poster presentations are displayed on the first floor. You all are welcome to visit at your convenience. Thank you.
Hello. Please have a seat, please. Please take your own seat, please.
Assalamu alaikum and a very good morning. This is Dr. M.D. Jahidul Islam from Dhaka Medical College. Now, going to start our session. This session having our Honorable Chair, Professor Dr. Monwar Hussain sir, Professor Dr. A. Alam Chaudhuri sir, and Professor Dr. M.D. Akhtaruzzaman sir. Our first speaker of this session, Professor Dr. Sumit Gujral. This topic is lymphoma in head and neck region. I'd like to invite Professor Dr. Sumit Gujral.
Thank you. Thank you very much. Thank you very much, Dr. Karim, to have me here and the team from TMH. We are very happy and it's a proud privilege for us to be here, all of us. My first talk, can I do the other talk first, the IHCs, the basics of IHCs? Is it possible? Or shall I do this talk first? The basic of IHC, if I do first, will be better. Can I do the other talk?
Basic of IHC, sure.
Shall it be better? IHC, so that,
Sir, you can together.
I can do both the talks together.
15 minutes, sir.
20 minutes.
Okay.
It's a 30 minutes talk, so I'll combine both the
sir.
talks and I'll save time because I don't think many surgeons will be interested in lymphomas other than few of my friends.
Thank you, sir.
So I'll try to do it small, and I don't want to bore my friends here. So what I'm going to talk is about a little bit about IHCs, which is now mandatory if you are doing oncology. If you are doing cancer surgeries or cancer medicine, immunohistochemistry is mandatory. In India, we have almost 900 medical colleges, out of which
only 15 or 20 medical colleges have IHCs. Rest colleges have ER, PR, or HER2/neu, which is not IHC, which is a predictive marker actually. If ER, PR is positive, it's not diagnostic. It is just predictive. You can give hormonal therapy. So the proper IHC, when you say cytokeratin, EMA, LCA, and a panel, a decent panel, there won't be more than 40, 30 or 40 medical colleges in India. So I do not know. I'm sure something similar will be in Bangladesh. We think it's expensive. Yeah, it's here. So for a pathologist, means even for a surgeon, when you talk about diagnostics, for a pathologist, obviously microscopy is bread and butter. But then equally important is a good history and clinical examination. Now, I think that as the new generation is losing touch with clinical examination and history taking, which is an art. So and we make a lot of mistakes. I can tell you about my lymphomas. If I don't take history, I make blunders. So I give you an example. I never diagnose a peripheral T cell lymphoma in a child. Similarly, I don't diagnose B cell lymphoblastic lymphoma in adults. So we know that B cell ALL is a disease of children, and I know that the peripheral T cell lymphoma is an adult disease of old age. I know that Hodgkin's lymphoma cannot occur below the diaphragm. Hodgkin's lymphoma always occurs above the diaphragm. If I do not know these clinical findings and history taking, I'll go wrong. I'll show you some examples. And third is the specialized techniques, which include immunohistochemistry. Okay, gone. Third is this, yeah, IHCs, molecular and flow. So, but basically we need IHCs, molecular is available as I mentioned in very few centers in India. Even so, if we are good in our good morphology, we teach our residents, I'm talking pathologists, and also if they know how to do correlate, basically. History, clinical findings, we will do a very good job without IHC. So even if you don't have IHCs, we don't have to crib, we can do a decent job. So diagnosis of any cancer, it's not leukemia, lymphoma, it's any cancer, starts from a good history and clinical examination and routine tests in the lab, routine markers, and then a good quality biopsy, HB section, which needs then followed by specialized techniques. So we detect proteins. Proteins we detect by IHCs and flow. This is basically antigen-antibody reaction. Then we do chromosomes. We have 23 pairs of chromosomes in our body. Pairs. And we look at those chromosomes. We can look at them by karyotyping, where we put all 23 chromosomes on a plate. And we look at if anything is abnormal. And second is FISH, protein in situ hybridization, where we do only one marker. Let's say you're looking for 1p deletion in brain, or HER2/neu in breast, or c-MYC in lymph node. You need that marker, and you do a FISH, and you can see fluorescent signals, and you say, oh, this is positive for HER2/neu, score 1, 2, 3, whatever. So this comes in cytogenetics. So cytogenetics we do by conventional karyotyping and by FISH. Conventional karyotyping gives a lot of information because you see all 23 chromosomes. FISH gives you only specific information which you are looking for, like BCR-ABL in CMS. It will not tell you, it will just tell you BCR-ABL is present or absent. Conventional karyotyping will give you all 23 chromosomes. You can see all, and you get a lot of information. But the problem with conventional karyotyping is it is labor intensive and it needs experts. FISH is very easy. Any pathologist can do FISH. But for conventional karyotyping, you need experts. Then third technique is molecular. So from proteins, molecular cytogenetics, and then smallest molecule is molecule ATGC level. So here basically we do PCR based tests. We do polymerase chain reaction based tests. That's we do in lung, EGFR. We do BCR-ABL in leukemias. These are PCR based. And the next level of PCR is now what is the hot in the market? Next generation sequencing, NGS. So once again, protein detection by IHC and flow. IHC is done in solid tissue. Flow cytometry is done in blood, liquid tissue. Cytogenetics by two methods, karyotyping and FISH. Molecular primarily methods, PCR and NGS. Now PCR again, then we will look for one mark. NGS we can get 200 mutations at one time. So in PCR we do one mutation at one time, mostly. You can have multiplex PCR, but again, it's very few. But in NGS, which is next generation sequencing, we do 200 mutations at one time. So we put the sample in the machine, and we have a big panel of 200 antibodies, 200 mutations. And machine will tell you, is it a FLT3, DNMT2A, TEC2, which mutations are present. Because now the times have changed. But when we did MBBS, we were not bothered about mutations. But now there are so many targeted therapies, the prognosis is different. So now my colleague Dr. Sabina is here, she'll tell you pediatric children ALL. 90% of pediatric ALL in United States are cured. 80% in my hospital, Tata Hospital, Bombay. If I go to some peripheral medical college elsewhere in India, it comes down to 45-50%. Now, why? Let's talk about 94% in America. Why 94%? Why not 100%? Because even pediatric ALL, there are good, bad, and ugly. And they all depend upon these molecular abnormalities. There are some molecular abnormalities which are bad ones, really bad. So that is the job of a pathologist to tell pediatric oncologists, this is a really bad one, this is less bad, this is good. Which is a good ALL? Hyperdiploidy ALL. It's very good, 100% cure. These all tests are required not only for diagnosis, also to tell good, bad, and ugly cancer, and also to decide and tell which targeted therapy will work. Like if HER2/neu is positive, this will work. If Herceptin is positive, if BCR-ABL is positive, this drug will work. CD20 is positive, this drug will work. If EGFR or RAS mutations are positive, these drugs will work. So this is the role of a pathologist. The pathologist's role starts from diagnosis and includes prognosis and prediction. Prediction means which drugs to be given in this patient. So as a pathologist, we need surgeon's help to get a good quality biopsy. Biopsy is very important now. Now, these days we get needle core biopsies in Tata Hospital. We don't get whole node because needle core is easy, quick, but the material becomes very small. Pathologists sometimes have problems. So if you are doing needle core, because it's a fast procedure, easy procedure, I only suggest my radiologist friends and my pathologist friends, please give us adequate cores. So if you're doing core biopsy, needle core, give us 8 to 10 core pieces, maybe 5 cores in each tubes, so that pathologists have enough material to opine. And it's a OPD procedure, needle core biopsy. So most of the radiologists, and in Tata Hospital, I'm sure like here in BMU, we have interventional radiologists. And we have Suman with us. Dr. Suman is not here. Dr. Suman, he gives us great biopsies. He's an interventional radiologist. So he goes to retroperitoneum, mediastinal, wherever you want to go, he will go and give you 10 beautiful cores. And a pathologist, I'm very happy. I can now go do a decent job. Second is, we have to make sure as a surgeon, don't use blunt needles and forceps. Sometimes, you don't have whatever funds, you don't have this thing. If you use the blunt needles and forceps in OT, you crush the tissues. And if you crush the tissues, then pathologist cannot. He will report crushed biopsy. Then you say, oh, pathologist is bad. Or you say, the processing was bad. Started from the surgeon. So, so you have to take the blame, equal blame as a pathologist. So we have to be careful because we have taken the patient to OT, we have spent so much time, effort, money, might as well do a good job. So we have to be careful that we don't use blunt needles, forceps, and other material which can crush tissues. And now this is a job of a pathologist team. And again, I would like to tell surgeon friends, when I ask my surgeon friends in India, when I leave Bombay, I go to other colleges, which is the best fixative? You know what they tell me? And I ask the young surgeons behind, what is the best fixative tissue which you send in tissue which? Formalin, very good. But in India, many surgeons send it in the normal saline. So the tissue gets autolyzed. I do not know in Bangladesh if they are doing it. If they are doing it, please tell your surgeons, do not send tissue in normal saline. Because they think that normal saline is the best fluid in the world. Because any patient in ICU, if you can't give glucose, give normal saline. So they think even the tissue will go in normal saline. Best fixative is 10% neutral buffel formalin. Formalin, you just remember one word. Please send tissue in formalin. This should be a policy. As a senior surgeon, please teach your junior surgeons and teach the nurses. in the OT. Do not send tissue in normal saline. And I'm telling you, in Dhaka, in Bangladesh also, they would be doing it. If they are doing it in India, we are brothers. We are same, this continent. So these are the three techniques I told you. Immunophenotyping, these are the special techniques. So in my hospital, I have a histopathology lab, and then I have a immunophenotyping lab, which is immunohistochemistry, flow cytometry, two labs. I have cytogenetics department, which has karyotyping and FISH. I have a molecular lab, which has PCR and GS. So there are three different departments in subunits in my lab, and they all work together to give a final report. So final report will be like, if it is a squamous carcinoma of buccal mucosa, does it have any HPO? Does it have any mutations? We'll mention that. So it gives a complete report. Now this is not Canada. This is Kargil in North India. So you must visit Himalayas. They are so beautiful. This is in the fall time. So the fall time is in November. It's the best time to visit Kashmir and Ladakh is in the month of November when everything becomes red and yellow. So this is the way flow cytometry looks like. This is the way immunohistochemistry looks like. Both detect proteins, as I said. Protein, what is a protein? You have RNA, RNA becomes DNA, DNA becomes protein. So protein is detected by immunophenotyping. This is flow cytometry in the blood. This is in the solid tissues, biopsies. The advantage is this is multicolor, this is single color. I won't go into the details. Now, as I said, IHC is mandatory in cancer management now. If you are doing oncology, if you are doing benign ENT surgeries, it's perfectly fine. But if you decide to do surgeries, maybe now HPV has so much role. Sometimes you have a poorly differentiated tumor, you do not know it's a squamous or adeno, you could do some stains. I'll show you some examples. So IHC has a role. And then I told you, there are some carcinoma where you can, even in head neck, salivary gland, you need HER2/neu. See the example. So IHC is kind of mandatory now if you are doing onco based practice. You're oncosurgeons, you're an oncoradiologist. So it's a good idea to develop your own IHC. If you have a busy hospital, please train your pathologist. Do not send samples to Dhaka main hospital or to India. Develop your own labs, work with your pathologist, and help them learn rather than send all samples outside. Because if you do not help your pathologist learn, then the younger generation of pathologists will also not learn. So the country loses, you lose, the country loses. So send samples to your pathology department. Don't send it to outside. We tell the same thing to Indian medical colleges because they send all to the big private labs. Surgeons send immediately tissue to the private lab. So what we tell them, you please send it to your own pathology department. Let them decide which samples to go to the private lab. Otherwise, your pathology department will not grow. What is IHC, as I told you, is an antigen antibody reaction. I've told you this. So if I have to find if there is Dr. Asawri in this room, I have to have antibody for Asawri. I'll put antibody and it'll go and bind to Dr. Asawri. So this is antigen antibody reaction. And then we add some coloring reagent which will tell me in the microscope, it will shine. Oh yes, Dr. Asawri is shining. So I know that she's in the room. Sorry, Asawri. I remember your name. So this I told you, and IHC is used to diagnose the type of cancer. So IHC will not tell you it's a cancer. IHC will tell you type of cancer. Sometimes it can even tell you it's a cancer. I'll show you some example. But it tells you it's an epithelial tumor, mesenchymal tumor, hematolymphoid tumor, germ cell tumor, melanocytic tumor, or something else. So there are 4 or 5 common types of tumor. Epithelial, carcinomas, sarcomas are mesenchymal. Then you have germ cell tumors. Then we have hematolymphoid, you have melanocytic. You need, sometimes morphology is very difficult. Pathologists cannot do it. We need to do IHCs. This is again in the Himalayas in India. This is not Switzerland. This is like Kargil and Ladakh. You see this beautiful glacier? This is called as Drang Drung Glacier. This is near Kargil. This is 3-4 hours. If you have a bike, you can drive, or a car, you can take. If you need any guidance, please call me. I'm a travel agent. So workflow, I'll just quickly show you how this happens. This is not maybe of interest to you, just briefly tell you how you make a slide. So, you send tissue, we make blocks, and then retrieve the antigens. We use some special pressure cookers to retrieve the antigens, and then with other methods we put some antibodies. This is antibody vial. Like this could be cytokeratin. You can do 100 tests of cytokeratin if I open this vial. So what do? When I open this vial, I make aliquots. I put maybe 1 micro or 20 microliters in each, so that every time I don't have to open the vial. So this vial I open, and this vial I make small opened off tubes, and I made 100 of aliquots, and I keep in the fridge. So daily I remove one cytokeratin, and I do my one test. If I have 3 tests, I remove 3. Otherwise, if I keep it open, I lose antibodies and they expire also very fast. So this is a good idea to make this kind of aliquots. You have to have calibrated pipettes. If you don't have calibrated pipettes, from 20 microliter, you may take 40 microliter. You may go wrong. So you have to have good quality control. So then you do multiple steps and you get beautiful HND IHC slide. And in our practice, mostly it's a brown color. This brown color is positive. This blue color is negative. Brown color is. So this is CD3, which is a T cell marker. So these all are T cells. This is CD20. These are all B cells. So this is the way antibody looks. Antibody can be in the nuclear, like ER, PR in the breast are nuclear, and MIB1 is nuclear. Even P63 is nuclear. Then it could be membrane, so cytoplasmic. So I won't go into the details of this. This is okay. It can be in the Golgi. Then you have to be very careful. Sometimes a smart surgeon will always catch pathologist. A smart oncologist will catch a pathologist. I don't agree with your diagnosis. Please review it. So if you do not agree, because you have to see this is a case of Hodgkin's lymphoma. So I'll make one talk only of both the talks. So I'll spend 1 minute on Hodgkin's lymphoma, which is the commonest lymphoma in children. So this is a Hodgkin's. These are the Reed-Sternberg cells. If all of us have read our MBBS, RS cells, these all. And the background cells are histiocytes. So if I do IHC, I have to see these cells, which are very, very scanty. They are only 2%. Rest 80%, 90% cells are inflammatory cells. I'm not interested in inflammatory cells. I'm interested in tumor cells, but they are very scanty. So as a pathologist, if I do IHC, look at this LCA. LCA is all positive in all cells, but I'm interested in tumor cells, which are negative. CD30 is positive in these cells. So so you have to know cells of interest. So if you do not agree with the diagnosis of pathologist, you have to call him again or call her again. The quality of your IHCs, sometimes they write negative and you don't agree with pathologists. You know this is a rhabdomyosarcoma or riving sarcoma, and your pathologist writes, oh, MIC2 is negative. You have to ask him or ask her, did your controls work well? Every IHC has to have controls, positive control, negative control. So without controls, do not believe your pathologist. So you can always ask your pathologist, did you check your controls today? Every day you do controls with every slide. Without controls, do not believe. Because if says, now this is negative, this is weak positive. Now I will say this is dead negative because there is not even a single cell positive. I have to have one cell, normal cell, positive. But ALK1, you don't get normal cells. Then I have to put an external antibody. So there are issues in IHCs. IHC is not a jadoo. IHC is not a magic. It's a garbage in, garbage out. So if you have to use your common sense, your history, your clinical findings, and your morphology. I'll repeat. Surgeon or a pathologist or a medical oncologist or a pediatrician or radiation oncologist has to do history, clinical findings, and morphology. IHC molecular will take you wherever you want to go. If you want to call it lymphoma, you say, oh yes, I agree. If you say I want to call it carcinoma, cytokeratin is weakly positive. Cytokeratin can be positive in many sarcomas. Vimentin is a useless stain. It has a very, very limited role. Please do not buy Vimentin for your lab. Buy some other markers. Vimentin comes positive in lymphomas also. Can come positive in carcinomas also. Can come positive in melanomas, germ cells also. So Vimentin used to be said as a mesenchymal. It comes strong in mesenchymal tumors. It is not helpful. We do not use Vimentin in our lab. Yeah. So controls are very important. This is an example to show you. This is a breast cancer. You see? So this is a negative, this is a tumor, IDC breast. Tumor is negative. How do I say tumor is negative? Because the ER is worked in the normal. And PR is also normal. This is a normal. Normal ducts are positive for PR and ER. Tumor is negative. Now I can say confidently that tumor is negative. Why? Because the normal ducts are ER, PR positive. This is called as inbuilt control. If I do not have this inbuilt control, this could be dead negative, dead negative. So I may be wrong. So you have to be very careful about your quality of your immunohistochemistry. So it's always good idea to have inbuilt control, and every breast will have normal ducts. Even if you have a cancer, you take a section as a normal area and the tumor area. In the normal area, ERPR will be positive in the normal glands. And if your tumor is positive for ERPR, it will be positive. Here, it is negative. So I'm confidently saying this is negative for ERPR. Yes, I told you this. Over? Okay, I think time is over. I have both the talks together, so I'll just finish. So, role of IHC in head and neck cancer, I'll quickly go. Yeah. 5 minutes, I'll go. So it helps in diagnosis. So these are the common markers for epithelial, for hematolymphoid, for melanoma. And primary tumor TTFN for thyroid, PAX8, GATA3 for breast, PAX8 for renal, CK720 CDX for GI. These are the common markers. So then you have prognostic markers, then you have predictive markers. I've told you all this. HER2/neu is a very important marker. This is a case of lymphoma where you do LCN to CK20 is positive, so this is a large B cell lymphoma. Then again, and more important, this is important case. I'll take a half a minute. This is a nasal destructive lesion, midline lesion. It's a destructive lesion in a adult male, and you do multiple biopsies. They're all necrotic, all necrotic. You rule out a high-grade lymphoma here, which is called as angiocentric T and K cell lymphomas. They come as a midline. It's a destructive lesion in the nose, paranasal sinuses. Patients look very bad. You can't see the patients. They look very horrendous. And it's a necrotic tumor, so sometimes you have to do 2-3 biopsies. So you have to be careful there. I think sometimes you get sarcomatoid carcinomas in buccal mucosa. Thanks to Asavri, she has given me these slides. Sarcomatoid tumors, they look like sarcoma. But in buccal mucosa, it will always be squamous carcinoma. It can have a sarcomatoid appearance. So it's a good idea to do some stains like cytostatin, A1A3, it's positive. But it's a carcinoma. If you still have a doubt, sometimes you do P40. P40 is also in squamous carcinoma. So this is not a sarcomatoid. So this is sarcomatoid variant. It's not a sarcoma. Okay? So I think you're getting up. Stop now. You didn't get up for anybody else here. Only for a pathologist they get up. Okay. I think. Yeah. Please tell me. Yeah. Yeah. Yes, of course. So if you have a necrotic tumor, first thing in our practice as a pathologist, we do stains for microorganisms. We do AFB for tuberculosis. We do GMS and PAS for fungus and viruses. But on a clinical suspicion, and this site, if it's a midline, we use the old name of angiocentric T and K cell lymphoma, which occurs here, is midline lethal granuloma. So here we have to be very, very careful. But we do stains for fungus and the AFB. Sorry? He says question answer later.
Thank you very much. Thank you very much, Professor Dr. Sumit Gujral from India. Now I like to call upon on the dais Dr. Shamim Hassan for presenting post-laryngectomy pharynx reconstruction. Dr. Shamim Hassan.
Assalamu alaikum. So many learned person. I'm very nervous. Still, I have to. Before starting my discussion,
Dr. Mohammad Hani. I will come later. There are some technical problems.
We are very sorry for some undue technical problem. Now I call upon the dais Dr. Mustafa Aziz Shumon for presenting what radiation oncologists expect from head and neck surgeons.
So good morning, esteemed colleagues. So it's really an honor to be here, especially when my direct teacher, Professor Monia Hussain sir, is there as a chairperson. Thank you, sir. Would like to give a special thanks to the organizers, especially my younger brother, Mitu, for arranging such a beautiful scientific program within such a short times. So he has given me a hypothetical talks, rather clinical discussions. What radiation oncologists expect from head and neck surgeons. So I am really not very sure whether I can fulfill his expectations from me. So let's start. So this is the ENT head neck conference, and why I have brought this vision test chart over here. You can see 6 by 6 is the normal. So here I have come with my 6 expectations from my ENT surgeons colleagues. So before the expectations, let's discuss two distinct approaches to cancer treatment. The left arm, the ENT surgeons colleagues, and the right arm, the radiation oncologist. The ENT surgeons colleagues physically remove the tumor, and radiation oncologist do the next. The complete eradication of micrometastasis with some sorts of irradiation. And here our gadgets are different types of linear accelerators. When we deal with mouse computer generated program called the treatment planning systems. But our objective is quite similar, the cure of our patient. Let's see how important role we play. If we individualize treat our patient, if we cannot combine the decision, we are going to lose 16% of our patients. So that's the immense responsibility. Together, we can bring 16% overall survival. So that's the responsibility. Make us really think about our collaborations. And with these immense responsibilities, I came here with my first expectations. As you know, multidisciplinary team approach is the standard of care, is the gold standard. But I am here in Bangladesh, I know the reality. This is not very possible to arrange the MDT in everywhere. So my minimum expectations, do a prior communications before taking the radical decisions. Whether it by telephone or writing a single paper to your fellow colleagues. So these are my decisions, whether you are agreed or not. I think this single communication may change a great decision, which ultimately can help the outcome of your cancer patients. As I have mentioned, these simple communications can improve 16% overall survival. So here you can see this paper published this June. They showed the diet. This is not dual. Radiation oncologists and ENT surgeons, if they take decisions in a diet manner, they improve the outcome, whether it is the resectability assessment, whether it is for the reconstruction planning or for optimum timing management. This all plays a very important role in the cancer care management. So this is very important prior communications. Number two, clear surgical margins. My dear ENT surgeons, when you are thinking for a radical surgery, please consider whether this R0 resection is possible or not. Because this is the foundation of this oncological success. This is not universal rule. You can consider NCCN generally recommended 5 millimeter, but this is subsite specifics. When you are going to treat glottic, maybe 1 or 2 millimeter. When oropharyngeal approach, robotic approach, 1 or 2 millimeter may be enough. Think about clear resection margins, because when there is a positive margin, we have to escalate the dose. Positive margin, we need to treat our patient with some sorts of concurrent chemotherapy. This ultimately changes the total scenario of our treatment. It brings a big area to be irradiated. Ultimately, it causes the toxicity. So think about the clear resection margin. My second expectations to you. If you can't achieve the surgical margin, please, again, my expectation number one, good communications. Let know your radiation oncologist colleague that the surgical margin is positive. This clear communication is very important. Why you have failed to achieve the margin? Is it for bone involvement? Is it for nerve tissue? It is for vascular engagement. So you should mention every piece of information in that paper. And if possible, please do a photograph for the sake of the radiation oncologist. And whenever you think you need to put surgical clips, give us an idea. These are the area that should need extra attention. Because always you should keep in your mind, because your radiation oncologist colleague don't have the privilege to see by their own eyes. So they totally depend on you and your documentation to get an idea why to treat, why to give less dose, why to give higher dose. So that's why we are totally depend on you, means the proper documentation. As I have already mentioned, why the margins are compromised, that is very important. Is it for anatomical constraints? Whether you have your scalpels preserve the functions or the vascular involvement. These are very important piece of information. Okay, my third patients, adequate lymph node dissections. So this is not a general principles rules, but at least try to extract more than 18 lymph nodes. This is our specific. I give an general idea. Try to get the adequate number of lymph nodes, because it is directly related to the outcome. It also gives a numbers of prognostic information. My expectations number 4, proper documentation if any clinical capsular extension is there. So particularly depend on the extracapsular extension information from a pathologist. If any clinical capsular extension is there, it is your duty to mention it in your operative notes, because this is the most significant adverse features. If there is any capsular extension is there, we need to give higher dose there. And this is a single information that gives us that we need to treat the patient therapy if there is extracapsular extension. So this is a very important information. So this is my number 5 expectations. If we can summarize all my previous expectations, you can find really I should say, with the radiation oncologist, want you a comprehensive operative note. Again, the 6x6 principles in these operative notes, what we do want. Number 1, the tumor details. Number 2, the lymph node details. Number 3, the resection techniques. Number 4, reconstruction method. Number 5, margin status. Number 6, clip placement. Please do us a favor, keeping all these 6 notes in your operative and give us a comprehensive operative notes. 6 by 6, I am in my last slides. So this is very, what I should say, minimal expectations. There's the timely referral. As you know, that to start radiation therapy, there is a green line. The time is 6 weeks. If you refer the patient after 6 weeks, there is no benefit with radiation therapy. So we have to treat our patients some sort of initiation with radiation therapy within the 6 range of time. If it is more than 7 weeks, steady state, every 30 days wait, we are going to lose 4.6% of our patients. So the proper referral is very important. Just keep it in mind, refer the patient with proper time. You, the ENT surgical colleagues, you are the main stakeholders. Globally, 77% of the MDT in the head neck treated by the ENT surgeons. And your journey starts with the very beginning, with the surgical interventions. You have a major role in adjuvant planning, in surveillance, and of course in the salvage treatment. But what we need from you, continuous partnership throughout the care. This is my last slide. 6 expectations from you. Number 1, please try to achieve adequate surgical margins. Please provide us a comprehensive operative note with the 6 pillars I have mentioned. Do optimum lymph node dissections. Please send the patient with proper time so that we can initiate our radiation therapy within 6 weeks, means 42 days. Whenever possible, take a photograph and attach it with the operative note. And last of all, very important, try to build early communications even by telephones. So these are the 6 expectations, and I believe I am not expecting too much. To fulfill, to align, to satisfy these expectations, you don't need any extra monetary allocations. You don't need any extra logistics. Just you need to change your mindset. Please come across and forget the word I. Rather, we should say we as a team. And if we can really fulfill our expectations, believe me, we can change the paradigm of head and neck cancer patients here in Bangladesh. Thank you.
Thank you, Dr. Mustafa Jeshuman. You fulfill our 100% expectation. I think you are perfect person for this topic. Thank you, sir.
Thank you very much, Dr. Mustafa Jeshuman. Now I am calling down the dais Dr. Shamim Hassan again, post-laryngectomy pharynx reconstruction. I think our technical fault is achieved. Please come on the dais.
Again, Assalamu alaikum. Again, I want to give thanks to Professor Abu Hanif sir, Professor Muhammad Yusuf sir, Colonel Azad sir, Dr. Abdul Karim Mithu, and Dr. Muhammad Hanif. Because I did most of my work with them, and without their help, this presentation could not happen. They are great enough to take the responsibility of these patients who needs laryngectomy with pharynx reconstruction. And they are kind enough to involve my team with them. So let's start. So, learned audience, you all know that larynx make the anterior wall of the pharynx. So after laryngectomy, defect will be in the anterior wall of the pharynx. Most of the time, this defect can be closed directly. The question of reconstruction arises when defect cannot be or should not be closed directly. So we, the plastic surgeon with head neck surgeon, when decide to reconstruct the pharynx, we had some goal. That goal is to uh, restore the continuity of the pharynx from oropharynx to esophagus so that we can get a proper wound closure and early healing. Patient can initiate swallowing and resume speech. And overall, the patient can get a best possible quality of life. One important thing is that when you have a uh, adequate facility to reconstruct the pharynx, the head neck surgeon has the freedom to cut adequate tumor-free margin. To fulfill these goals of pharynx reconstruction, our reconstruction procedure should be single stage. It should not be such that today I cut pharynx, larynx, and day after tomorrow or sometime later we could reconstruct the pharynx. And by these things, this reconstruction should be such that there will be short hospital stay and short interval to resume feeding and space, overall low morbidity and low mortality. And the tissue we reconstruct with such tissue that it can tolerate radiotherapy. Present situation, forget about this data. What thing is that there's large number of laryngeal carcinoma patients in Bangladesh, and certain percentage of them are need laryngectomy. About this should be 50% of laryngectomy should need some form of reconstruction. The practical thing is the number of reconstruction in Bangladesh is low. Multifactorial, but one thing is there is lack of facility of reconstruction also. But due to the daring effort of the head neck surgeon I mentioned, I am blessed with some experience to get. I started doing pharynx reconstruction in 2011 with Abu Hanif sir in Sir Salimullah Medical College. Since then, till 2025, we have done 51 cases of pharynx reconstruction. You are seeing 11 of them had direct closure, but we reinforced the repair with pectoralis major myocutaneous or myofascial flap. 32 of them had partial defect. We reconstructed with some patch of fasciocutaneous flap, and 8 of them had circumferential defect. We some protocol that we would reconstruct the partial defect with pec major flap and circumferential defect. Procedure we made, yes, we had to use some DP flap in 2 cases also. The defects are, there are 3 types of defects. This defect can be closed directly and closed directly also. This is partial defect which was repaired with a patch fasciocutaneous flap, and this is circumferential defect which needs a tube reconstruction. And flap we used, this is pectoralis major flap, this is anterolateral thigh flap, this is radial front flap. But when we started reconstruction of pharynx, we faced some challenges. Challenges, you know, that all these patients, most of these patients has radiotherapy. They are systemically not very fit. And one thing is very practical, they are economically exhausted. So most of the cases we have to do in government setup. And one thing is that from our parts, we had no institutional training or exposure from anywhere. So we started doing this reconstruction from getting tips and tricks from our honored head neck surgeon. Let's see some of our cases. This was a partial wall defect which cannot be closed directly. So we used pectoralis major mycocutaneous flap as a patch to reconstruct the defect. This one is circumferential defect, which we reconstruct with ALT tube. And look, the lady, here the lady, he readmitted in the hospital for, she was readmitted in the hospital for her tracheoesophageal prosthesis. So the confidence, look the confidence in her face. This was the partial defect. Though our protocol was we will reconstruct the partial defect with pectoralis major, but this was a female patient. So pectoralis major is very difficult and not suitable, so we decided to reconstruct it with radial foramen flap. This was a secondary reconstruction. That means his operation was done earlier and he presented with loss of neck, skin and flap, and there is a large laryngocutaneous fistula. We reconstructed it with high-low pectoralis major flap. This was a very complicated case. There is recurrence in neopharynx. So with imaging, we came to know that he has also invasion in the right common carotid artery. So the surgeon excised the whole cancer. There is the common carotid artery on right side, which has residual tumor, but to be segmental resection is planned. All things is ready. And after excision, we put a PTFE tube in the common carotid artery, and then we reconstructed the pharynx and the final result. Please look the smiling face of the patient and his wife. This is our achievement. Outcome. I will not discuss in detail the outcome. Rather, I will discuss about the one complication, because these complications severely affect our outcome. That is fistula. I want to present these cases because of this complication only. In our setting, our overall fistula rate was 65%. One important thing that in partial reconstruction it is 75%, but in cases of circumferential reconstruction it is only 14%. And with free pedicle flap it is 80%, and with free flap it is 20%. But this is very so severe disappointment for the patient and for the surgeon also. This is the common scenario of our reconstruction. Very disappointing scene. What happened? When fistula occurs, the main goal of reconstruction is failed. The early healing, that is short hospital stay, that is resume of feeding and speech, all things are lost. So this is very source of frustration. And real danger is that in some cases there is possibility of IGB, internal jugular vein, or carotid artery blowout in case of fistulas. We are fortunate that our latest 5 cases with reconstruction with patch or circumferential reconstruction, we had no fistula. So why this happened? Is this our experience that we get, or patient factor, or post-operative care, or flap factor? We are confused why this happened. Actually, when we try to evaluate all our cases, one thing surprising us that all these patients, the last 5 cases and the other cases where the fistula not occurred, got the flaps which were thin. That is, just look, 2 pectoralis major flap. This patient has pectoralis major faciocutaneous tissue which has tough dermis, thick tough dermis, and his pectoralis muscle is very bulky and subcutaneous fat also. But that patient has very soft and pliable with limited subcutaneous tissue. And another, these two ALT flap, anterolateral thigh flap. This lady has very thick dermis and subcutaneous tissue, and this lady has very soft and pliable tissue. So we came to an inference that our flap should be thin enough, of course vascular enough, and then without, in spite of all the efforts, we have to face some fistulas. And for these fistulas, we have to take care and precaution very early. So in most of cases, I do wrap the internal jugular vein and common carotid artery with muscle. It may be with sternocleidomastoid or muscles from our flap, because this will prevent your blowout and avoid midline fistulas. Drain tube in the lateral part of the closal line, so that if fistula occur, it will go through the lateral side of the neck, not in the midline. What problem with midline fistulas? Midline fistulas is very difficult to get healed and very complicated for the patient to take care. So these two things, the wrapping the internal jugular vein and common carotid artery with muscle, and try to avoid midline fistula. This was our protocol. So the take-home message of this presentation is to make our flaps for reconstruction thin and pliable. So we changed our protocol. Not strict that we will reconstruct our partial defect with pec major and circumferential defect with free flap. Not that. If required, we can reconstruct the partial defect with thin free flap also. And in choice of free flap, we will prefer thin flap like radial forearm in case of thick ALT. In our plastic surgery, one basic thing is same tissue lost should be replaced by same. So what could be better than laryngeal transplant? So I wish and expect our future generation will work in this. And our team is always ready to be a part of this great work. This is our team, always ready to help you. Again, thank for your patient hearing. Thank you.
Thank you very much, Dr. Shamim Hassan. Now I'd like to call again on the dais our international speaker, young and energetic, Professor Dr. Shobit Gujral, importance of immunohistochemistry in head and neck cancer. Sorry, there is the mention. I like to now our presenter, Dr. Ahmed Khushairi Khalid. He will speak on robotic surgery in head and neck cancer.
I hope you can. Yeah.
Okay. I'm saying a few words about Ahmed Kaisuri Khalid.
Thank you,
from Malaysia. Dr. Ahmed Khalid is graduated from Royal College of Ireland, and he was basic training in the Royal College of Ireland and University of Malaysia. And he has got latest robotic training from Malaysian University and Ireland and Yanchai University of Korea. And now he's working at the University of Malaysia and he has a lot of presentations in all over the world and about the robot. Okay, now he's the mainly advisory committee of Malaysian and faculty member of Malaysia and the robotic surgery team. So now I request Ahmed to say a few words about the use of robot in head and neck cancer. Thank you.
Thank you so much for the kind introduction, Professor Safiullah. And I would like to thanks Prof. Dewan Hassan, Dr. Karim for inviting me. And today I would like to talk about robotic surgery usage in head and neck cancer, an overview about this technology and how it can help us in managing head and neck cancer. I would like to thank the organizer for inviting me for this talk. Just to check, can you hear me? Yeah? Can you hear me? Yeah? Yes, firstly, it's about, okay, firstly, to introduce about the technology, some basic principles in terms of the usage, some experience. Here. Thank you, Prof. Some case highlights, some experience sharing, what the paper says about this technology, a little bit about training, and also the future about this technology. I would like to make a disclaimer that I don't have any financial affiliations with Da Vinci. So for the interest of time, I might go a bit faster. So transforaminal robotic surgery for head and neck is relatively newcomer, but it's not that new. It has been described in 2005 where they perform a laryngectomy in cadavers. In Malaysia, we have started this program in about 2018. So it has been 7 years that we have done transforaminal robotic surgery. Just to give an idea about how the robots have evolved since its inception in 1999 until the latest version this year, the Da Vinci 5. So a lot of improvement has been done. The robotic size is smaller now. There is tactile sensation. You can really feel the tactile. The view is high definition and the arm is really lightweight. So all this improvement has been done over the years. So it all helped us to assess the oropharynx, hypopharynx, supraglottic area very well. So this is the FDA approved transforaminal robotic usage, mainly for oropharynx, nasopharynx, of course, thyroid as well. So I just would like to highlight that it's not just Da Vinci. Now we have a lot of soft tissue robots available, be it from China, India, and it is now much more cheaper and affordable because even in Malaysia, for last year alone, there has been 15 installation of robots in throughout the country. So they also come up with a lot of robotic arm instruments for us to fulfill our purpose of surgery. Just to introduce that this is what I used initially in my center, the robotic Da Vinci SI, they call it, before I moved to a later version of XI. So if you see the XI, the last video, it's the latest one that we have. It has a target beam, the green area where it can help us to target where in the oral cavity that we want to resect. The arm is lighter, but unfortunately it doesn't have any tactile yet. We haven't got the Da Vinci 5 that has the tactile sensation. I also had a chance to test the Flex robotic system in Germany previously. It has not been used since. So just to introduce a little bit about some of the robot types. So the principle of this robotic technology is essentially automation and precision. So how much the robot can control and how much we can give the command is varied. So for head and neck surgery, mainly is level 1 and level 2. The robot takes the command from us and we will command the robot to do it. But, in orthology, they have come to level 5. It's totally robotic control. Cochlear implant has been done. So maybe something that we can ponder in the future. So why this technology extensive laparotomy wound, so it can give better quality of life post-op for the patient. The robotic arm But if the tumor has involved the mandible, if it has fixed to the vertebrae, or the tongue base has involved too much, or if it has encased the carotid or major vessels, so these are the contraindications. So this to show how we set up the robot in our center. You have the control central processing unit, the robotic arm. You only need one or two assistants with you, and the robotic console. And this is how we dock, drive, and brake the robot. Draping and dock the robot. So we need to know as well that what are the challenges. Yes, so I just want to show that some of the cases that might give you difficulties in operation theatre include this kind of patient. So always assess the patient pre-op. The dental status, edentulous patient, very difficult to open their mouth. Trismus, small jaw, thick neck, all can be difficult to assess transorally. So just to show on how we assess the oral cavity, always warn the patient about numbness at the anterior tongue, Boyle Davis mouth gag will be used, and always test all the arms so that there's no collision when you do the surgery. So this is the how it looks before the operation. Nasal intubation is always treatment of choice so that you can assess the hypopharynx and supraglottic better. Very important slide. We need to really discuss and assess what is the best treatment outcome for the patient. Basically, to clear the tumor fully, means tumor clearance, while preserving the organ function and give a better quality of life. So always weigh between open surgery and robotic surgery to give the best outcome for the patient. But what I have learned is if you detect the cases yang belum ada. These cases is not suitable for robotic because it's too large. You see the tongue base involved too much. As well as these cases, because of the tumor has encased the carotid. So these kind of cases are not suitable for robotic. Some case sharing, left tonsillar carcinoma. Of course, this kind of surgery can be done conventionally, but with availability of the robot, you can really delineate the tumor and also the underlying pharyngeal muscle very well. Take all the margins that you need for frozen section, and you can perform extended tonsillectomy very well for tonsillar carcinoma with this. This is the real advantage of this technology. In case of tongue carcinomas, you see how the robot arm with a small movement can really delineate the plane between the tumor and the underlying superior longitudinal or palatoglossus muscle of the tongue. Usually you can take more tissues after you have excised the primary tumor, and I routinely do frozen section, take all the margins anterior, posterior, and the side margins before uh, finishing the operation. Usually, packing is sufficient to stop the bleeding, and this is how it looks post-operatively. So usually the wound will heal by secondary intention. In another case of tongue carcinoma, early stage tumor, delineate the tumor so that we can excise and get the plane between the tumor and the healthy underlying tongue muscles. Before I take more margins at the tumor bed or at the surgical site bed, and then send the anterior, posterior, and side margins for frozen sections. So this is example on how this technology can really change the patient from undergoing extensive mandibulotomy. I would like to highlight as well, this is the same. This patient is a nice case. You see at the hypopharynx area, tumor here, very difficult to assess. Conventional have been done, but unable to clear the tumor. This is the tumor anterior at the supraglottic level, just below the epiglottis. We cannot visualize the vocal cord. So with this usage, we can identify and delineate the tumor margins before we excise between the tumor and the healthy tissues underlying it. Usually we pack below to prevent aspiration. Of course, when you go deeper, there are a lot of smoke and charring that will occur, so you really need a good assistant to assist you. Just for the interest of time, I will show it to you how the tumor or the post-operative look. This is pre-operatively. As you can see, the tumor in front of the vocal cord, and this is post-operatively after we have cleared the tumor. In this patient, I already discussed extensively. If the tumor recur, of course, he needs to undergo open surgery, but it's a good stepping stone before we go for open surgery. Another base of toxis case, as you can see, recur after conventional method. With this technology, we can really delineate the tumor to remove it in total. So very nice case to highlight the advantage of this technology. Yes, this is another case at the base of tongue tumor. Very difficult to biopsy, as you can see in the MRI, the sagittal plane, it's at the base of tongue, so it's very deep. So what we did was we create a flap to assess the area before we expose the tumor to do an excisional biopsy of the tumor. It turns out to be SCC. As you can see, after we have elevated the flap, we expose the necrotic tissue of the tumor. You can see the paratoglossal muscle underneath the tumor later on. And as we go deeper, we can even demonstrate the central necrosis of the tumor here. You can see as we excise it before we put the cavity for hemostasis. Again, we take more tissue as we go deeper into the tongue muscles. And the interesting part that we also learn, just to highlight, is how we suture the cavity after we have taken out the tumor with the robotic arm. We start to do more suturing now, and maybe we are also collaborating with the plastic surgeons for suturing flat intraorally, but that will be in the future. And this is the look of the wound post-operatively. That's the epiglottis underneath the tongue base. Last case that I would like to share is robotic tumor with still functioning vocal cord. The tumor is just above the vocal cord, so we delineate the tumor margins at least 1 centimeter from the tumor cells, resect it between the tumor and the healthy tissues, do some packing for hemostasis, and you can see that we can able to visualize the vocal cord post-operatively. Some things that you can encounter, which is the dorsal lingual artery or branch of lingual artery, can sometimes give you trouble example, intraoperatively, but you can safely clip it. Some of the wound that can occur post-operatively, especially adhesions, secondary bleeding, and hypertrophy of scar, can cause the patient to have problems. But of course, careful advice will, especially asking them to chew, to swallow, eat a lot of chewing gum post-op. We can avoid all these things from happening. I just like to share about what Tim says about transoroptic surgery as compared to surgery. Of course, it has for early stage tumor, it has a better functional clearance as compared to conventional open surgery. De-escalation, in terms of de-escalation of adjuvant radiotherapy, it also has been found that a long-term follow-up for patients, it shows that transoral robotic surgery is able to give de-escalation from full dose radio and chemotherapy over 2 years of follow-up in terms of tumor clearance. How about quality of life as compared to full dose chemoradiotherapy? Transoral robotic surgery for early stage tumor give better quality of life, especially in terms of dry mouth, dry sensation, xerostomia. In terms of speech, swallowing is about the same. In terms of tumor clearance, it's also about the same. Again, this is early stage study. More study need to be done to establish the true findings of this. Just to highlight as well, for carcinoma of unknown primary, we can superior to access the tongue base area and excise the mucosa of tongue base utilizing this technology as well as described in this paper. I would like to share as well that the training that we are running now in Malaysia, if any one of you are interested, there are 4 stages of the training until level 4. And the certificate is coming from the Intuitive Technology USA as well as KPJ University from Malaysia. Just to show about the simulation that is available in the Da Vinci machine. And now we have incorporated holo medicine as well. I would like to share on how my trainee is not with me in Kuala Lumpur. Yang mana? It's here. So just enjoy. So, the surgery done elsewhere, my trainee is elsewhere in part of Malaysia. The technology provider is in Germany. So we have done telesurgery and tele-training surgery with this technology. It's very good technology to explore, and we can do borderless training now, and it's good to have that. Yeah. Okay, now I go back to this, and just to share with you as well that now we have embarked with this single pot, which really has break the boundaries. We haven't got the chance to test it in Malaysia, but it has been widely used in Florida and also in Yonsei, Korea. This can really break the boundaries. We can even go to the glottic and subglottic area to help the patient more. Hopefully we can have this soon in Malaysia. And they also have established a society of single port robotic head and neck surgery. This is when we have our ESHNO conference with Professor Koh from Yonsei. So it will be done next year, inshallah, in Korea. So single port robotic head and neck surgery truly for ENT and colorectal, mainly rectal surgeon, but mainly is used for ENT. I would like to highlight as well some of the experience that we have done. This paper really depicts on how we started, how we sustain, and how we maintain the program, some of the challenges that we face and how we overcome them in a middle income country like Malaysia. So it's a very good paper for countries who are starting the program. So I think that non-invasive technique with shorter hospital stay and good tumor clearance, and also organ preservation. We can save the patient voice. The message here is early detection, early treatment, and we can achieve this goal. And then it's good that we offer this technology to our patients now. And with that, I thank you.
Thank you, Ahmed, for your nice presentation. It's an amazing presentation in our country. We hope near in future. We're waiting for the robot. There are some center in the ADA. They are doing the robot. In our country, we are near in future. We're waiting. Another technology for you. Thank you very much. Thank you.
Thank you, audience. We're running short of time, so I'd like to I request our Manwar sir, Professor Manwar sir, for say something and conclude the session.
Bismillahirrahmanirrahim. There are 4 topics covered in this session. I must thank Dr. Sumit, Dr. Shamim, and Shuman. Where is Shuman? Shuman, and these 3 actually they present their topics, I think, very nicely. I would like to say a few sentences or something regarding the pathology. Actually, if you know the disease, if you treat disease, if you planning the treatment, I think pathology is mandatory. If you know the pathology, then you can no need of memorize symptoms and signs. So pathology is very important. Regarding pathology, I want to say something regarding. Actually, we send the biopsy. Sumit, I think he talked about the process of sending the biopsy. Taking a biopsy, if you excise the lymph node, don't hide it, don't divide it. You send the whole lymph node. Otherwise, if you divide two, in one section it will be positive and one section it will be negative. So if there is any doubt, you review the slide or block. But don't divide the the lab's material. This I think Sumit, yeah, it is very important. And another 2 things, cytogenetics and immunohistocytochemistry. If you want to know the prognosis of the disease and the nature of the disease, I think these 2 things is very important. In case of lymphoma, if you don't do the immunocytochemistry, then you cannot plan the treatment. Is it, Sumit? So this is very important. I want to share my knowledge, and these are all about the pathology and radiation. Actually, Lubna is here. Yeah, she's my student. There are so many students in front of me. Actually, it is very difficult to fulfill your 6 expectation. But we try to send the, when we send biopsy or when we send the patient after surgery, actually we almost we fulfill your requirement. One thing I want to know, ENT surgeon, especially that sinonasal malignancy, somebody send the patient directly to the oncologist. Find it. First of all, surgery, then you send the patient. It will be beneficiary to the patient. It will be beneficiary for oncologist. This is one of the messages. And first of all, reconstruction. Shamim is here. Where is Shamim? Left. Yeah. Actually, I know him very well. when I was in this institute working here. Sometimes we call him and to do reconstructive surgery. Regarding reconstructive surgery, there are so many young studies there in front of me. You please develop yourself. I want you develop yourself for reconstruction. There are so many stars in front of me. This is my message and this is my request to juniors. You please develop yourself for reconstruction. I think it is not so difficult. Shamim, is it? Not so difficult. You please train my students. Okay. The robotic surgery, actually robotic surgery is not still starting our country and in our domain. Near future, I think it will be developed. Again, I request my junior colleagues and students, you please develop yourself. World is running, world is going ahead. So if you develop yourself, you will be happy for yourself as well as our country. So these are all about the topics covered in this session. I think everybody explained everything very nicely. I give thanks all the speakers. Thank you very much. Thank you very much.
We sincerely thank our distinguished chairpersons, moderator, and speaker for their invaluable contributions and for sharing their expertise with us. I request the honorable sirs to take their respective seats in the audience and enjoy the rest of the session.
Welcome everyone. We are pleased to begin our panel discussion and we hope you find it insightful as well as enjoyable. This deep dive session that explores the topic comprehensive management of laryngeal cancer. The respected panelists of this session are Dr. Ratan Shetty, Professor Dr. Aswari Patil, Professor Dr. Sumit Gujral, Dr. Sisal Thamachan Kanikal, Dr. Rukmangathan. This session will be moderated by Dr. AFM Kamaluddin sir. I request our honorable sirs to please come to the stage and take their seats. Our moderator, Dr. AFM Kamaluddin sir, is a renowned radiation oncologist and former head of the oncology department at NINT, having recently retired from our institution. He is well known to many of us and has contributed extensively through his internal publications. At present, he is working as senior consultant in Labit Cancer Hospital, Dhaka. Thank you, respected.
So, good afternoon, everybody. I want to thank you for giving me the opportunity to ask him, because this is the most critical time that when you are talking in between lunch and the session. So, we are going to have a panel discussion, not a tumor board. That is the first thing that I want to mention. So that's why I want to have a discussion, not presentation. So I love to sit from here and talk. এখানে কি কানেকশন দেওয়া যাবে নাকি আমি এখানে বলবো? দাও। Okay, so topics is deep dive into management of laryngeal cancer.
And my name is Dr. F.M. Kamaluddin. I'm an ex-faculty of this institute. It's always good to come back to my center. Now I'm working in Rapid Cancer Center and also in a hospital. So start with name of Almighty. I'm grateful. My acknowledgement to the director of the institute, Dr. Hassan Zafar and Abdul Karim Mithu, organizing team. And my acknowledgement, I have taken some web pictures. And I have a special thanks to Dr. Sumit Gujral, because when I was putting the name of my faculties, I was very happily put the name of my pathology colleague as Ashiri. Because to me, it is a very common name, but then I learned that it is Ashawari. Thanks, Dr. Gujral, for correcting me. So today we're going to talk about larynx cancer. So if we want to walk through the history of larynx cancer, we know that the Crown Prince Frederick of Germany was diagnosed larynx cancer in 1887, and the founder of laryngoscope, Mackenzie, diagnosed him as a laryngeal cancer. Biopsy was done. Unfortunately, the total laryngectomy was the only treatment, and he refused, and he passed away. And then Kaiser Wilhelm took the throne, and he led the First World War. So 2022, this German journal, they published an article that 125 years back, good organ preservation saved the World War I. And they have put a timeline. So I want to say that if timeline was like this, that after the diagnosis, without surgery, if Dr. Hermann Gotch was there, who did the first curative treatment of radiotherapy for larynx, and he could treat the patient, and he could save, then the king would be same crown prince. Probably there was no World War. So the organ preservation could change the world. So that was the first starting. So let me introduce my panel members. Suman Kumar is the radiologist. Ashawari Patel is the pathologist. Rupangan is my speech and swallow therapist. The Caesar is my fellow radiation oncologist. And Ratan Sethi is my friend, not the enemy, the surgeon. And especially Dr. Sumit Gujral is a, I will say, mentor with me. So we are going to discuss on all these areas. So it's always to start with this case, a very classical case of a supraglottic cancer. Patient presenting with this type of history. I'm skipping it for the sake of time. When the examination was done, they found a growth in the supraglottic region, and the biopsy was squamous cell carcinoma. So, we are blind without radiologists. So, Suman, in this situation, the $1 million question, to do CT or MRI. Everybody knows, everybody is confused.
Yeah, there is a growing controversy regarding the use of MRI, but I would say CT is the modality of choice. So most of the laryngeal cancer patients, they would have a breathing difficulty, and MRI takes about 30 to 40 minutes. And for a patient to hold still for that amount of time in a asphyxiating or breathing difficulty patient, it's very difficult. So practical difficulties is one thing. And second thing is the problem solving nature of MRI is only required if at all if you are contemplating prevertebral fascia involvement or very early cancer where the laryngeal cartilage involvement is not very clear on CT, then MRI can be used. But ideally, CT scan is go-to modality.
Thanks, Roman. So I was showing some papers that NCCN telling both the thing, but putting an oblique, making my life difficult. And there is paper in favor of CT, there is paper in favor of MRI. As Suman said, everybody have its pros and cons, so no one is the best. But this paper I love. We should select based on our available machine, our resources. If my radiology friend is very good with CT, why to kill myself with MRI? If he is comfortable, he wants MRI. So it is not mandatory we need a CT or MRI. Both is great. We need to judge according to the situation. First one, nothing ends nowadays without PET. In this situation, when you think we need to do a PET?
The baseline investigation of PET-CT, I wouldn't recommend until unless it's very advanced disease. So stage 3, stage 4, only if you are contemplating a distant metastasis, then PET-CT would be recommended. Otherwise, early curable cancers, even if you do a PET-CT, I would say CT component is required for evaluation of the local extent of the disease.
Thanks, Shuman. I mean, this is something crazy. Modern world is pushing these things. They have published a paper in stage 1 and 2. They are upstaging cities and so many fancy words. But in our world, in reality, sometimes in this region, it can create a havoc. You can pick up something lightning and we don't know what it is. And one lightning in mediastinum make the whole story changed. And neither me nor my surgeon colleague and it will go to the medical oncology for chemotherapy. So just PET-CT can upstage. PET-CT has many good sites, but standard, we can say that for us, only for advanced stage, when we have some indeterminate situation that we need to take help, we can take a help of PET-CT. But in oncology, radiation oncology sometimes love to get it because there is upstaging of nodal status around 20% with PET-CT, which is sometimes helpful for us and really identify, delineate the situation. But as a primary modality, probably not. So moving to my pathology colleague, we know majority is squamous, but we know there are so many other subtypes. Is there any message if I'm getting a other subtypes, not squamous? Does it giving me a message?
Yeah, so we do get, besides squamous, we do get sometimes neuroendocrine carcinomas, and where we need immunochemistry, if they are high grade, the medical oncologist may want to step in. Minor salivary gland carcinomas are there. So for our diagnosis of all this, besides squamous, for all other tumors, we will need ISC. Immunohistochemistry is mandatory for diagnosis of this. Even for poorly differentiated squamous cell carcinoma, we can use ISC just to make sure that we are looking at squamous cell carcinoma and nothing else. Sarcomas rarely can occur and other tumors can occur, but most common is squamous cell carcinoma.
Yeah, thanks, Shavari. I mean, that is the important thing.
Sorry, I have a question to you. How many cases of laryngeal carcinoma you will need ISC? You see 100 cases of laryngeal squamous carcinoma. In how many cases you need ISC?
It's no, very few, maybe less than 5%, I would say.
This uncommon pathology is around 5%, and when there is a doubt, we can do IHC. But the main message is that we may have other than squamous. 95% squamous, we need to think like the lymphoma. It can. It may be anocervical gland. From therapeutic, from a clinician perspective, it is squamous with for preservation. When it is non-squamous, we go for surgeon friend that can you please take it out. So very quick comment about this, DOI, LVSI, and PNI. Very quick comment.
So DOI at present is only matters for oral cavity cancers, not for squamous laryngeal cancers or any other cancers. LVI and PNI definitely in resection specimen, we have to comment on that. They don't change the stage, but definitely prognostically they're important. DOI is the depth of invasion, and which is important for oral cavity. LV is lymphovascular emboli, and perineural invasion is PNI.
Yeah, so I brought this issue intentionally because, we are very commonly using DOI, but unfortunately larynx is not a candidate for DOI. But LVSI is very important, but we always ignore PNI. PNI is a very big culprit when it is for surgeon and also for radiation oncology. We need to take care of PNI when we see, because it's a bad prognostic marker. So, and it is not only from the primary, even in the recurrence setting, PNI is a prognostic marker. It's a higher chance of recurrence, and OS and DFS both is low in PNI positive. So, colleagues, when we see PNI in the report, put a caution flag in your mind that we are dealing a bad disease. So, everybody thinks that HPV P16 is a huge thing. Anything about HPV in?
So HPV test, usually what we do is P16 immunohistochemistry. At this point, it matters only in oropharynx, where the treatment will change, and that's a totally different group, which is HPV positive or P16 positive. Rest of the organs, including oral cavity and larynx, some tumors may be HPV or P16 positive, but at this point, I don't think there is any treatment change. So it's not mandatory.
Yeah. Even there is meta-analysis, we don't need to read the meta-analysis if it is not clinically impeccable. There are around 20% of the HPV positivity reported, but not by P16, but then you need to do by, classical HPV, not surrogate by IHC. But There are some indication that it may give some survival benefit, but till now it is not a recommendation. So we don't need to kill ourselves with HPV in larynx cancer. This is the $1,000,000 question. I have done the neck dissection. I take out 20 nodes. Somebody says I take out 30 nodes. Somebody says I take out 40 nodes. What is the magic number?
So at this point for head and neck, especially squamous cell carcinoma, if you are doing selective neck dissection, even up to level 3 and 4, ideally at least 18 nodes, we should be able to pathologically dissect them. We are lucky enough that our surgeons send them level wise. So we always make sure that minimum 18 nodes are there.
So thanks, Ashawari. Once I asked a surgeon, Catherine, how many nodes you take out? She said, I don't take out nodes. I take out fat. My pathology colleague count the nodes. For me, I need to clean the area, take out everything, and give it to him or her. So the main objective is, if we want to target an area, level 2 and 3, we need to clean that total area. And the pathology colleague will count and tell me, yes, you have done right, because you have taken out minimum 18 nodes. So that is it is not that if it is 70 is a disaster, 19 is a plus point. It is something, a magic number, but we need to do adequate. So we first ask, who is the surgeon? When we are the oncologist, we ask, who is the surgeon? Then we don't count the node first. Sometimes it is not properly counted. Revisit can increase the number of nodes. So moving from pathology to speech and swallow therapist. First question, why you are here? It's a discussion on larynx cancer. What is your role here? Why you are here?
Of the patient care.
Thank you. I'm very sorry to embarrass you for the blunt question. You see, for us, the Bible is NCCN. NCCN says he is the member of the team, so he is here. And then, why he is here? If you look at this British guideline, they are telling that they have a huge work which I didn't knew. Thanks to Karim for giving me this opportunity. When I was making this slide last night, I went through that. I thought he only helped us to talk. No, he helped us for many things. For radiation oncology, he helped us do the preventive exercise and prevent CCT. And before surgery, before intervention, during the first assessment, they are there. So they are there from the beginning. When we leave them, they are there. So they are the longest period staying with the patient. So quickly, regarding, beside this speech pathology, what the support you provide, like preventive measures?
In preventative swallowing exercise will be given to the patient, and during the weekly radiation follow-up will be seen in with respect to need of feeding tube, weight loss assessment, and the safety of swallowing. And then in the survivorship also we will be assessing the patient if the patient is at risk of any penetration aspiration. In late radiation oncology, after treatment, patient can also have swallowing issues and symptoms. So that time also we will be assessing the patient and giving support during that.
So after laryngectomy, do you wait for the costly implant for the voice, or you start with something?
Usually in current practice that it has been done in the primary setting itself. So most of the patient we have tracheoesophageal processes at the beginning, or it has been twice prior to the treatment, either electrolarynx or tracheoesophageal processes. So the counseling will begin prior to the treatment. Pre-laryngectomy counseling itself will know whether the patient undergoes whether tracheoesophageal processes or electrolarynx.
Thank you. So we understand that he is a very important member, and we need him from the beginning, not after the radiation is done, after the surgery is done, and go and meet the pathologist. No, it's too late. He will say, sorry, you are too early for the next session. I wanted to meet you much earlier. Thank you. So to my colleague, Dr. Sizzle, patient, going back to the patient, the MRI was done, there was a big mass around 4.5 to 4 centimeter. And there was bilateral lymph nodes, and there was no involvement of thyroid cartilage. So for this patient in the tumor board, will you opt for keeping it to you or giving to the surgeon?
This patient, what about the hemilarynx fix? No.
It is hemilarynx free. Hemilarynx is free.
Free. Okay. So I understand it is a T2 bilateral nodes are there.
Yeah.
N2C, T2, N2C, stage 4 disease.
Yep.
And if the Rukmadan say that okay, there is no aspiration, no dysfunction is there, then if the patient is having good performance status, less than 70 PS1, and good clear creatine clearance and functional larynx, the treatment is to go for a concurrent chemoradiation program.
So my friend in the tumor board, he is, so please don't blame me bias because I'm a clinical oncologist. So he want to take the patient 4.9 by 4 centimeter for organ preservation. It's coming from you.
Question, you have put up a slide of induction chemotherapy. So currently the evidence for organ preservation is for CTRT. There is a role for induction, but if you can give CTRT upfront, CTRT is the treatment of choice. If you think it's a large volume disease, the patient may end up with stridor during the course of radiation, then we can consider chemo selection, that is give induction chemotherapy.
I was asking, will you try to pull in your coat for the surgery? Yeah, please.
Regarding induction or whether we should take the patient for chemoradiation, although he wasn't based on RTU 9111, there was a numerical there is benefit in terms of induction chemotherapy that was not statistically significant. And comparing the induction versus concurrent, the organ preservation and laryngectomy, the locorodal control was better in patients who received concurrent compared versus induction. So if there's no airway compromise, and if I feel that this patient is a T2 disease, and if I feel that there is no airway compromise, then okay, for the sake of changing for a better, this one I will not give induction chemotherapy because there is no hardcore data. Even if you look at the GOTAC 2001 clinical trial, that include larynx and hypopharynx patients together. So in case of a hypopharyngeal tumor, T2 bar, T3, large bulky tumor, my pendulum may swing more towards induction. But for a laryngeal tumor, if you look at the RTUG 9111, the 5-year laryngeal preservation is around 84%. So you need not give induction chemotherapy and to assess the response as such. Okay, so I'm not a fan of giving induction chemotherapy if it is not that there is no. If I feel that the patient will not need any tracheostomy in between, if there's an airway compromise, definitely I will give induction. Then I will send the patient, and always I will reassess with an endoscopy, and if the airway is clear, then I will take the patient first.
Thanks, Aman. I intentionally, brought it because other than nasopharynx, first chemotherapy in head and neck is not a candidate. There was a campaign in favor of larynx, but it is going out. As Dr. Cesar said, the long-term data is more in favor of CTRT for organ preservation. Even the final OS is comparable, but the conservation is high on CTRT. So we, the oncologists, now prefer, other than NPC, though where first chemotherapy is. Some trial is going on with immuno, but it is yet to mature. For my non-oncology colleagues, that other than nasopharyngeal carcinoma, we don't prefer chemotherapy as the first, curative. We don't take the chemotherapy as the first. So if I consider that T2 is somehow it was T3 actually. Okay. So what will be your call?
T3 again, if a patient is having T3, can be due to different things. If a patient is having a supraglottic primary, then the T3 can be due to 5 things. Okay, it may be due to post-cricoid involvement T3, a paraglottic fat T3, the patient is having a pre-epiglottic space, it is T3, inner cortex involvement is T3, and hemilarynx fix it is T3. In all other situations, in all 5 situations, if there is no signs of dysfunction, there will not be any change in the treatment. Again, it's a T3 and bilateral N2C nodes. Again, it's a stage 4 disease. The patient will go for chemoradiation.
So very aggressive. Don't want to allow the patient to lose the voice. Voice is important. Any comment? Such a good agreement. And that is I love. That we are not fighting. We are working together. It is not pulling patient from each other. We are pushing patient to each other. So, but when the volume is chiseled, if it's T3, the volume is.
There is a data from US University of Florida saying that if the patient is having a large bulky tumor in T3 disease, there may be a chance of residual disease, and this patient may be treated with surgery. But in this in 2025, we cannot clearly say that, okay, and even in very bulky tumors, and if there is any very bulky disease, still it is T3 and no dysfunction, you have always an option of giving induction chemotherapy to facilitate an organ preservation rather than taking the patient for a surgery followed by adjuvant program.
Yeah, so you see, there are some centers that believe that volume is a factor, and there are many publications they are putting
That's why it's the university program.
they are using this data that something cutoff of 6 cc in supraglottic and 3.5 cc glottic is a cutoff for a bad predictor. Why all this thing came out? Because of this. You see, if you look at the data of this National Cancer Database, and with the time frame when the laryngeal preservation was going high, the mortality was somehow going low. And nobody knows exactly, from this data cannot give the exact picture. You know, this person, Olsen has a hypothesis. Maybe we are not doing justice for selecting the proper patient. So in the name of preservation, we are preserving the voice, maybe affecting the survival. Yes, Jazal, any comment?
Yeah, the selection is very important. If you look into the paper in the VA trial, the first study which included the evaluated the organ preservation, even T4 patients were treated. So, and if you look into the salvage rates versus T4 versus non-T4, the proportion of patients underwent for salvage surgery was 56%, and patients with non-T4 it was 28%. It is double. So there was a selection by us, and the patient with all the dysfunction larynx were all given the chemoradiation because there was a propaganda saying that. Even if you look into the adoption of total laryngectomy in National Cancer Database, if between 2000, although paper was published in 2003, there was a late adoption for total laryngectomy even in this one T4. The patients were reluctant to accept T4, total laryngectomy. That's what I understood. And they evaluated the results. It was found that in T4A disease, the survival is better with surgery followed by adjuvant radiation, and non-disease chemoradiation is better.
So to be on, balancing. Any
Yeah,
comment?
it's a balance. Yeah.
T4, I would, if there is no cartilage erosion, I will still consider CTRT. Always try to preserve the larynx, because you can salvage do a salvage laryngectomy and rescue the patient. A vast majority of the times you would be able to do a salvage laryngectomy. If there is no cartilage erosion and if there is no stridor, no laryngopharyngeal dysfunction, definitely consider CTRT.
I love to have this surgeon in my team that who is always pushing all the patients to me. Yeah. You see, unless cartilage, he is not considering anything. This is the spirit. Actually, in 2025, what Cecil was telling, that there may be many data. We need to take the realistic approach. So, Cecil, there is a big volume. I'm scared that there will be edema. So there was a discussion. Shall I put a tracheostomy tube? I ask a debulking, or I wait, give some steroid. What is your practice?
Okay, so this is what we practice. The patient with a frank stridor, the patient will be sent to the surgeon for a tracheostomy. Okay, but if the patient is having mild stridor, okay, and if supraglottic like this, patient will have a node. I will admit the patient on that day itself. I will ask my resident to take an FNSC, and then I will discuss with the pathologist on that day itself. In the meantime, I will take an emergency CT scan and arrange for a creatinine clearance, everything, cardiology consult on that day itself. I will start the patient on cisplatin 5-fluorouracil in the night and avoid a tracheostomy. And I will counsel the patient that you may require a tracheostomy at any time, and you should be prepared for that. So if there is, that is there. I think there was a question regarding the debulking. I think debulking is no more considered as a standard approach or laser excision or this one. Please, now you can achieve a very good cytoreduction. 80 to 90% of squamous cell carcinoma larynx will respond to induction chemotherapy. Only 10% will not, 10 to 15% will not respond. So take it from me, give the induction chemotherapy, and that patient will be taken for reassessment after 1 or 2 cycles of chemo. And you do a repeat endoscopy, rule out an aspiration or any other dysfunction, take the patient for CTRT.
So patient came to Karim. He found big notes. He thought, let me help Dr. Kamal, take some note out, make some debulking, make his life easy, and send it to me. Can you comment?
That's again, I think there was an approach which was studied in Tata. Then the study was discontinued. The annual professor by Anil De Cruz, do a neck dissection, then you would give chemo radiation. No, again, that concept really didn't work. If a patient is a large, bulky N3B disease with extensive skin involvement, the first and foremost question I ask you, I'm dealing with a stage 4B disease. Do I need to treat the patient with a radical approach or whether I should tailor down the treatment for a palliation? That's number one question. I will always discuss with the family regarding these outcomes. Which I'm dealing with a stage 4B disease, the outcomes, even with my induction chemotherapy, then do a surgery with there's always an extra capsule extension. You very good radiation with 7 degree with chemotherapy. Still, there is a high chance for relapse in the primary, and then also systemic relapse. So this has to be very clear, and this is we have to bear in mind. And all these patients, I prefer if we, for starting them for a radical approach, always we should have a CT because these are the group of patients with large N3 nodes. Should have a PET CT before considering them for radical approach.
Chisel rightly mentioned about Shumon. I was coming back to Shumon. On the $1 million issue, cartilage involvement. You use some tricky word, erosion, subtle change. I mean, sometimes we don't understand. So, what is your language when say do surgery, don't do surgery? How I understand?
So now with the focal erosion of inner cortex and abutment of cortex would not change management. So irrespective of whether the cartilage is focally eroded or abated, it will not change the management. So I am not worried. Only I am worried when outer cortex is involved. So if there is a true and true invasion of or cricoarytenoid gap, then I would report it in that way. But I should not be worried about a focal erosion or only inner cortex erosion. So the thyroid cartilage is discontinuously ossified. So there is always a false interpretation of focal erosion. So if only inner cortex is eroded or abutted, either the surgeon or the radiation oncologist wouldn't mind. So we should not go into the nitty-gritties. But I should be very confident in saying that there is no outer cortex or medullary involvement.
So the message is very clear. Inner cortex erosion is not a contraindication for preservation. And Suman, Dr. Ashik was very patient. Anesthesia has done the pre-anesthetic checkup. They have said that the X-ray chest is fine. So, as Mr. Yazal was telling that we are dealing a 4A disease or 3B, I mean, quite a really advanced disease, I will rather say, not putting the stage, or a laryngectomy case or a preservation. Are you happy with the X-ray chest? Clear?
No. See, now at least minimum NCCT test has to be done. CT thorax.
So this I find many times in my colleagues that surgery is done with the basis of X-ray chest, and it was clear. Unfortunately, X-ray clear is not a clear, at least today. So if we are doing a curative resection, Dr. Chazal was telling, when we are dealing with this type of indeterminate case, we push to get a PET CT. Because we really want to know, before putting 70 gray or putting a knife or laryngectomy, we need to really know whether we are dealing a metastatic disease or not. Similarly, when we are doing a curative resection or we are doing a curative treatment, we need to be very clear the lung is clear. And the lung clear is at least a CT scan.
If the PET CT is not available, then at least a minimum of a CT thorax should be done.
Situations I'm really concerned to do have a systemic workup, systematic, the distal metastatic workup. It's any node, lower node. Okay, even if it's a very small node at the root of the neck, level 4 node, then it is alarming. It's a small nodes 2, 3, 4, but it's a level 4 node. It's really alarming. Or any N3 node. These are situations I always ask for this one. It need not be. You cannot categorically say that it should be CT. There's no evidence to say that, but at least CT thorax should be done. There's no evidence to say that PET CT is superior than CT thorax. Again, most relapse is systemic relapse, systemic failure. This one disease is in the lung or in the mediastinal nodes. So we cannot categorically say that we should have a PET CT. We should have at least a CT thorax.
Yeah, I say that when we do a PET CT, it don't allow the patient to sleep and the doctor to sleep because they come with, doctor, there is SUV 3. This it. We cannot say anything. Whether it is, so one of my radiology colleagues said that it is SUV stupid up value. So there it is. So, I mean, so this is a situation where we need to really do the workup clear the patient is a candidate for a curative treatment when we are dealing a borderline situation. Unfortunately, don't need a help of a surgeon for do debulking outside the larynx or inside the larynx. Because if I need all or none law. Either you cut it through or you don't touch it, except biopsy. Because if you do the neck dissection and send it to me in this room, in this place, KP Agarwal made the same comment about the DeCruz trial because one colleague asked, what about this? And he said, well, we thought it will be helpful, but finally it came out it was not helpful. So Tata had an experience, 100 patients, and they stopped it.
Because the main concern is that when you do a neck dissection and the patient is undergoing chemoradiation, next eventually what will happen is that there is a delay in starting the definitive treatment for the primary. And second thing is that the patient, sometimes the patient may not have enough reserve to undergo the planned CTRT. Okay, these are all concerns.
So, I mean, don't mix it with carcinoma of unknown primary. That is a different world where we invite you to do the neck dissection. Other than that, if it is and even I say lymphoma. Kamal, I have done that debulking. Now I send it to you. And I cannot say, sir, you have done a disaster. I cannot say, fortunately, that is a disaster if something is done like that. So please, we should touch the neck there. Who knows better than you? Touching neck is a jukebox. Those don't open it if you don't need it. So I am sitting in NINT. It is the surgeon's domain. How can I ignore my surgeon colleagues? So, CTRT is done. Patient asks in my country, he moves on, who is my owner? Is it the surgeon or the oncologist? So they love to go back to the surgeon because they love surgeon because they have a knife. They are very powerful. So they come to you. What is your follow-up protocol?
Keep the patient under close observation. So following treatment, you can assess the patient after 2 months, 3 months, do a laryngoscopy. Immediately following treatment, you can assess for the response and do a laryngoscopy. Imaging is recommended 3 months post-treatment. That is, PET-CT is recommended. If you don't have a PET-CT, you do a CT in head and neck and thorax. The reason why PET-CT is recommended is because you want to see the response to treatment. If response is not there, then we can always salvage the patient.
Yes. Yeah. Regarding the first scopy, when to be done. So whether to be done at 8 weeks or 12 weeks, okay? Because if you do there are advantages and disadvantages to doing an early scopy. The advantage of doing an early scopy, he said 2 to 3 months, that's right. So if you do it endoscopy at 8 weeks, and if you say that the patient is free of disease, the patient will be happy, we can reveal a good news to the family. But it's a double-edged sword, actually. But if you do an endoscopy and if there is a residual disease after 8 weeks, so in that situation, then it will have, okay, we are not doing anything. We are not taking biopsy. Are you taking biopsy? No. Are you planning salvage surgery? No. We have to wait for another 4 more weeks. Then we will do an endoscopy at 12 weeks. Then only we'll take a biopsy for considering a residual disease. So radioresidual disease can be, you can say that it is a radioresidual disease only at 12 weeks period. So now after the COVID at our institution, we have stopped doing endoscopy after 8 weeks. And now we routinely recommend the patient to come after 12 weeks to have an endoscopy.
So you see, they read my mind. I was putting it slide later on. He put it early. Problem is, in addition, we do the first follow-up after 45 days. So in other sites, I mean, normally we say come after 2 months or 45 days. But in head and neck, problem is, as he said, when he comes to the surgeon, do a FOL, and the follow-up, you see that different people are talking different follow-up guidelines. Nobody knows what is the best follow-up guideline. And here in the institute, once I made a presentation on follow-up, and I found that unfortunately there is no survival benefit of different follow-up. And when I made this, my director was, what the hell you are telling Dr. Kamal, nobody will do a follow-up. But the cards is that if I do something before 3 months, that what is brought out very correctly, you see a edema, sometimes somebody take a biopsy. And story start there.
That's suicidal.
Never do a biopsy in a post-static case. Only wait for the imaging, only then you do. You will incite a contour necrosis.
Not only that, no biopsy, but report. FOL report, residual, recurrence. So I am so frustrated, I started chemotherapy because patient has recurred, residual. So this cutoff time is 3 months. Magic number is 3 months. Before 3 months, we should not come to a conclusion that there is something after CTRT in the neck. This is a very important thing. That's why I mentioned this, that if there is even biopsy is negative, there is argument. You see, there is edema. I see it. So please, after CTRT, 3 months is a cutoff. Again, the time of PET CT is also a controversy. Many people talk many things. Somebody said 3 months, somebody said 12 months, somebody says follow up. But Suman, how I simplify it after CTRT, I want to use PET CT very judiciously.
So 3 to 6 months is the NCCN recommendations, and I mean they have not specified exactly do it at 3 months or 6 months. They said 3 to 6 months, and that too based on the clinical scenario. But all, if you are contemplating that there would be a residual disease, then do a PET CT at after 3 months. Or if you feel that there would be a complete response, laryngoscopy is normal. Just as a baseline investigation for the future follow-up, you do it at 3 to 6 months.
So very important is after 3 months, we should do the first imaging, minimum 3 months, it may be up to 6 months. But if it is negative, then we are having a very good news that there is a good prognostic line. And unless there is obvious thing, we don't need to do a very frequent PET CT for that. So that is indication. So, I mean, this patient, say we go back to the old patient, now coming back to the surgeon, because you need to give them some room, you know, I mean, after all, it was a very advanced disease. After 6 months, there was a residual, and they finally diagnosed that there is a local recurrence. So now, what is the extent? When there is a local recurrence, how far you will take out? Because you have an eye.
You're talking about the neck. I want to know the report. Is there any up in the neck?
Neck is totally clear, only local recurrence.
Was there neck was positive pre-op? I mean,
it was CN0.
See, I would not address the neck if the neck was negative previous to the treatment. If neck was positive, probably I'll do a ipsilateral neck dissection and a resection of the larynx. I would not address the already addressed neck by radiotherapy. If it was CN0 or but if it was neck node was positive, responded to chemo post, then I would do at least a ipsilateral neck dissection and laryngectomy.
Coming back to not risk recurrence.
Can I question?
Yeah.
So, if the possibly the patient had a N2A node and the no extract obstruction, patient had a say 3 into 4 centimeter, and the patient has primary in remission after 3 months, and the patient is having a say 1.5 into 1.5 centimeter in the residual node. So, what is the extent of neck dissection? No, I just want to know. Yeah. Okay, I'm sorry. So, what? Yeah.
Extent of neck dissection would be, see, in an N plus node, the evidence is for 2 to 5, but you can avoid doing a 5 neck node because the rate of level 5 metastasis is less than 10%. So you can safely avoid doing a level 5 neck dissection. You can do 2 to 4 neck dissection.
So there was a CTRT, there was a nodal failure. He took out the node. Will you re-radiate him?
That I should.
Or give chemo?
I should be on a gunpoint.
Yeah, I mean, that is
a re-radiation before 2 years. You know, if theoretically everyone say that you can do at 6 months.
Even
1
after
year.
2 years, say after 2 years.
Okay,
It was a radiated neck, solitary node. He took it out. Yeah. Patient is fine. PET CT is negative. Will you?
So, if the patient has no extracapsular extension and if the nodes are only without an extracapsular extension, I won't irradiate the patient.
So the message is re-radiation is a very hot cake, but very dangerous. I mean, it's like the barbarian surgery. If I'm a barber, I can cut everything. But if I'm a surgeon, I will thinking twice before putting a re-radiation.
Because there was a re-radiation consortium data published in Red Journal in 2018, which shows that there is some criteria to have a good outcomes. And one of the sites where there was no benefit was one larynx. Okay, so we have to, at least I will think twice, 3 or 5 times before irradiating a larynx or the neck for a laryngeal primary.
External extension, if it is there, definitely I would ask for an adjuvant treatment and I would ask for adjuvant CT also.
Yeah, let me give everything. I will put immunotherapy, so don't worry. So
doing just surgery in external extension cases.
Yeah. So if
any patient who have a relapse and patient surgery alone, fine. And then if patient is a candidate for re-radiation, then there's provision for re-radiation. That only I will send the patient for a salvage surgery. Otherwise, salvage surgery is out. Because patient require a re-radiation, and if I cannot give, like an extracapsular extension, if I feel that neck chemo radiation, then I will not be able to do that. So it's planned treatment if a patient is having extracatheter extension.
Helping the patient, if we know that there is extensive disease, extranodal extension cannot irradiate, I'll send the patient for systemic therapy.
So, if it is not a recurrent, it is a fresh case, you are treating a laryngectomy. What is your principle of clear margin? In all direction?
All directions.
Even if it is a clotting, everywhere it's a...
See, in a clot cancer, if I was doing a transoral laser surgery, I would aim for 1 to 2 millimeter margins, that is negative margins. But in supraglottis, transoral T1, T2 disease, at least 5 millimeter of negative margins.
Okay. So I go back to Sumon. 1 minute, one message you want to say, because we are at the end of our discussion.
So for laryngeal cancers, CT scan, the continuous CT scan of neck and thorax, the recommended investigation of choice. PET CT only in surveillance in post-treated cases, and that would 3 to 6 months, and then maybe later after 1 year or later.
Okay, now the pathology colleague, any message?
Well, when you are sending any biopsy, please inform pathologist what exactly you are looking for. And if it is a laser surgery, please show the pathologist, give it in nicely oriented on, as Dr. I think Khalid explained, nicely oriented specimen.
Thank you. There, one pathologist told that the one piece of tissue was there, and he had to call the surgeon that where from the tissue came, and then he could find out. Yes.
Transoral laser procedures always orient the specimen, because if the margins comes positive, you need to revise the margins in drop. So you need to orient the specimen and talk to the pathologist like where the margin is close or positive. I mean, in laser it's not close, it's positive, and you have to revise.
Okay.
So orientation is must.
Radiation colleague.
Okay, in early disease, when we radiate, we should have a proper data. Okay, regarding the endoscopy findings, we should correlate that with the radiology. Then always you should consider that. In advanced disease, always you should ensure that the patient is having a functional larynx. When we are dealing with a T4 disease with through and through cartilage destruction, always you should have a proper assessment of the general condition of the patient. The patient require an adjuvant program. And whenever you are dealing with T4B or N3, selection should be very good for a radical approach.
I forgot one thing. Do you put rice cube for all your patients when you are doing CTRT or wait?
No, sir. We usually do not initially, but always patient should encourage the patient to swallow. And when the patient develops dysphagia, always we should do it.
Reactive tube feeding.
Yeah, yeah.
So, very important. Again, my apology. I asked intentionally the blunt question why you are here. Because I asked myself when I go to pathology conference that why I am here. So I need to justify. Please, any comment?
Yes, speech therapist has become an important team member to maximize and optimize the functional outcomes. And along with the oncological workup, even functional workup should be done to understand the swallowing issues from pre-op and the post-treatment. The patient swallowing can be taken care of with proper assessment and management, along with the speech and swallowing therapy team.
Thank you. Moving to the surgeon. Last word.
Any case of CL larynx has to be discussed in MDT, and the patient choice has to be taken into account what the patient wants. And based on the best available evidence and the laryngopharyngeal function status, plan a treatment. Could be either organ preservation or surgery based on the stage of the tumor and the function of the tumor, of the larynx.
So I want to end with this word from Richard Simmons that common clinical problems are approached in diametrically opposite ways by doctors with similar training background, having read the literature, interpreting the available information differently based on unique personal experience, vision, and prejudice. So this is something very tricky. Same paper we are reading, we are interpreting different. So we have a Buzurg in the panel. So any comment from you, sir, about this? The interpreting same thing in a different perspective that can change the whole world. Any comment on that?
Enjoyed the panel, and I don't do much larynx, but I enjoyed it. And thank you, everybody. And I don't have anything to comment here. maybe you can take some comment from somebody else. I am happy. I don't have to comment anything.
So thank you. I was given 45 minutes. I've taken 5 minutes more. But you know, somebody said tumor board. I said, Mithu, let us put the name deep dive. But I realized, give a deep dive, we're going to take out everything because we were busy with the tip of the iceberg. Because time was the main problem. And in the whole world, we are running behind time and we are running for the time. So time is the problem, but we need to solve it because we come from this area, this region. We have an incredible experience, creativity, innovation. We can solve our problem in our own way. So we cannot wait for the robot. We cannot wait for everything. We need to solve our problem in our way. And they need to help our patients. Cancer patient should not have an excuse of boundary of not getting the best treatment with our ability. And sometimes we are teaching the world how they can overcome. People loves to come. I met people from overseas, Western country. They want to come and learn from us. So it is not, we are not taking like this. We are also doing like this. So it is a like this. So we hold hand in hand. So we should not feel bad. Sar was telling no IHC is not a bad feeling. No PET CT is not a bad feeling. We can do a great job. Larynx is something which could change the world. But we cannot change the world. We can change the life of a laryngeal patient. So we want to thank you everybody. Thanks all my panel members and hope you have enjoyed. Thank you very much.
Thank you, respected panelists and the moderator, sir, for enlightening us in exploring new path in the treatment strategy of laryngeal cancer. I humbly request our honorable sir to take their seat in the audience and be with us with the next part of the session. No, sir.
এখন আমাদের সবচেয়ে অ্যাট্রাকটিভ আইটেম কুইজ কম্পিটিশন আছে প্লিজ সিট ডাউন প্লিজ কুইজ কম্পিটিশন
Gujral sir, are you in any way associated with Inder Kumar Gujral, the former Prime Minister of India?
If I was associated, I won't be here. I would be there. Actually, he comes from the same village in Pakistan. My parents come from Pakistan, and I.K. Gujral was my mother's neighbor.
Okay, sir, sit down, have a seat. Kamal sir, please. Dr. Mahbub, bye.
Respected chairperson, my dear teachers and colleagues, Assalamu alaikum. Welcome to you all to this quiz competition program. Today's topic is larynx. I would like to request our sir, Dr. Najib Mohammad Ishadullah sir, to conduct the session. আমি একটু ইনস্ট্রাকশন দিই, যারা গতকাল রেজিস্ট্রেশন করছেন তাদের আজকে রেজিস্ট্রেশন করা লাগবে না। আপনারা শুধু কিউআর স্ক্যানার দিয়ে আপনার কিউআর স্ক্যানার স্ক্যান করলে আপনাদের রেজিস্ট্রেশন অন হবে। তারপরে আপনারা আপনাদের মোবাইলে কোশ্চেন দেখতে পাবেন। কোশ্চেন দেখার পরে আপনারা যদি কোনো ডিফিকাল্টিস ফিল করেন তাহলে আমাদেরকে একটু জানাবেন। সবাই কি রেডি?
একটু আচ্ছা, গতকালকে একটু বলা হচ্ছিল যে কেউ বোধহয় ইয়ে করতে পারেন নাই, রেজিস্টার করতে পারেন নাই বোধহয়। এখানে কিউআর কোডও আছে এবং একটা লিংক আছে, লিংকটা আপনাদের ব্রাউজারে দিয়ে, এই যে এখানে লিংক, এই লিংকটা আপনাদের ব্রাউজারে দিয়েও আপনারা এই ওয়েবসাইটে ঢুকতে পারবেন। আর যদি কিউআর কোডটা স্ক্যান করেন একই ঘটনা ঘটবে, আপনারা ওয়েবসাইটটাতে কুইজের ওয়েবসাইটটাতে ঢুকতে পারবেন।
কিউআর কোডটা বড় করেন, জুম করে ইয়ে করতে পারেন, স্ক্যান করতে পারেন, জুম করেন। একটু বড়। গতকাল কি করেছিলেন? তাহলে অনেকে বাসায় বসেও এই কুইজে অ্যাটেন্ড করতে পারবে, এই জন্য গ্রুপে দিচ্ছি না।
রেজিস্ট্রেশন কি সবার হয়েছে? শুরু করবো।
আজকে তো ডেমো নেই, আজকে সরাসরি কুইজ।
সবাই রেডি থাকেন মোবাইল নিয়ে। কোশ্চেনটা দেখা যাচ্ছে মোবাইলে? এটা পরের স্লাইডে কিন্তু কোশ্চেন থাকবে না, শুধু আনসার থাকবে। যারা নতুন এসেছেন তাদের জন্য বলি, সিঙ্গেল বেস্ট আনসার, যত দ্রুত আনসার করতে পারবেন তাদের তত বেশি মার্কস। প্রতিটা কোশ্চেনের জন্য 1000 পয়েন্ট। যে দ্রুত আনসার করতে পারবে তাদের পয়েন্টস তত বেশি বাড়বে।
এবং অ্যানসার চুজ করে ফেলার পরে আর চেঞ্জ করা যাবে না।
নেক্সট স্লাইডে যাবো
না, প্রশ্ন পড়তে তো এত সময় লাগার কথা না, আমরা কি এ সাহায্য নিচ্ছি?
না, নেক্সট
এতক্ষণ পরে কেন?
পড়ে গেছে। নেক্সট স্লাইডে যাবো।
আমরা রেজাল্টটা দেখি। পরবর্তী প্রশ্ন।
কোশ্চেন করা শেষ, নেক্সট স্লাইডে যাবো। বেশি সময় দিলে আর ইয়ে নিবে, হেল্প নিবে। আমরা নেক্সট স্লাইডে যাই।
আমরা অ্যানসার দেখছি।
জি জি, নেক্সট কোশ্চেনে যাচ্ছি আমরা।
পরবর্তী প্রশ্ন।
আরেকটা লাস্ট কোশ্চেন। আমার মনে হয় কোশ্চেন করা শেষ। ক্যান নট বি সিন, সরি, এটা একটু কানেকশন আছে, ক্যান নট বি সিন।
না না, এটা ঠিক আছে না? ঠিক আছে, ঠিক আছে, প্রশ্ন ঠিক আছে।
প্রশ্ন করা শেষ। নেক্সট স্লাইডে যাবো। জি জি, next slide।
একটা অ্যানাউন্সমেন্ট, আমাদের পোস্টার প্রেজেন্টেশন আছে, অনেকগুলো পোস্টারের মধ্যে আমরা 12টা সিলেক্ট করছি। তো পোস্টার এই যে এই কর্নারে রাখা আছে, আমাদের জুরি বোর্ড যাবে একটু পরে। আমি রিকোয়েস্ট করব আপনারা একটু জুরি বোর্ডের সাথে থাকবেন। জুরি বোর্ড হলো প্রফেসর কামরুল ইসলাম তরফদার স্যার, সুমিত গুজরাল স্যার, ঐশ্বরিয়া পাটিল ম্যাম, এন্ড ডক্টর সিদ্ধার্থ এন্ড ডক্টর রবিশঙ্কর। ওকে।
আচ্ছা, আমরা আপনাদের স্ক্রিনে এখন ফার্স্ট সেকেন্ড থার্ড আসবে। অফ না করে সামনে চলে আসবেন, প্রথম, দ্বিতীয়, তৃতীয়।
হ্যালো,
চলে আসেন, সামনে চলে আসেন। ফোন সহ নুজহাত নূরি ইসলাম, ডক্টর আবুল কালাম আজাদ, কিশোর কুমার চক্রবর্তী।
আসার জন্য অনুরোধ করছি।
প্রথমে যিনি থার্ড, উনি সামনে দাঁড়ান। হ্যাঁ,
প্রথম পুরস্কার গ্রহণ করবেন তৃতীয় যিনি হয়েছেন কিশোর কুমার চক্রবর্তী।
মানে আমাদের রেজাল্ট থেকে একটা জিনিস বোঝা যাচ্ছে, টোটাল মার্কস ছিল কিন্তু 5000 এবং কেউই সবগুলো সঠিক উত্তর দিতে পারেননি।
জি জি,
নুজহাত সবগুলো।
প্রথমে পুরস্কার গ্রহণ করবেন তিনজন। প্রথম যিনি হয়েছেন কিশোর কুমার চক্রবর্তী। ডিরেক্টর স্যার কাছ থেকে গ্রহণ করার জন্য অনুরোধ করছি। সবার জন্য করতালি।
পরিচয় 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 দিবে পরিচয় পরিচয়।
আসসালামু আলাইকুম, আমি ডক্টর কিশোর কুমার চক্রবর্তী। আমি স্যার সলিমুল্লাহ মেডিকেল কলেজ মিটফোর্ড হাসপাতালে আছি অ্যাসিস্ট্যান্ট রেজিস্ট্রার হিসেবে।
There is nothing in E folder, correct? Clear. Yeah. Nothing.
দ্বিতীয় পুরস্কার গ্রহণ করবেন ডক্টর ডক্টর
হ্যালো
আবুল কালাম আজাদ। পুরস্কার গ্রহণ করছেন আবুল কালাম আজাদ
সুমিত গোজল স্যারের কাছ থেকে।
আমি ডক্টর আবুল কালাম আজাদ, এফসিপিএস ট্রেনিং, কুমিল্লা মেডিকেল কলেজ হসপিটাল। থ্যাংক ইউ।
নেক্সট ফার্স্ট প্রাইজ নুসরাত জি
নুজহাত নূর ইসলাম।
পুরস্কার গ্রহণ করবেন কামালউদ্দিন স্যারের কাছ থেকে। হাততালি হবে ইনশাআল্লাহ।
পরিচয় দিতে বলো।
আসসালামু আলাইকুম, আমি মেজর নুজহাত, আমি এফসিপিএস পার্ট 2 তে আছি, সিএমএইচ এ বর্তমানে পিজি তে আছি। থ্যাংক ইউ। আসসালামু আলাইকুম।
ধন্যবাদ
ধন্যবাদ
সবাইকে। আমন্ত্রণ জানাচ্ছি পরবর্তী প্রোগ্রামের জন্য।
Hello, dear audience. Hello.